Great.
Yeah, it's right.
Okay, good morning, everyone. Are we ready to begin? Welcome to the Bloodless Medicine and Surgery Society meeting. This is day 3 with our theme, Compassion at the Heart of Bloodless Medicine. I am pleased to join you today with my co-moderator, who is Dr. Majed Rafai, who's a professor of pathology and laboratory medicine at the University of Rochester in New York in the United States. And my name is Becky Rock, and I'm a registered nurse leading a patient blood management program in Calgary, Alberta in Canada. We have 3 wonderful speakers for this session today entitled Bloodless Medicine and Surgery. And so my co-moderator will introduce each of the speakers, and at the very end, we will have about 15 minutes for your questions, and hopefully we'll get all of them answered during that time. So as you listen to the presentations, please do post your questions, and we'll do our best to get to those very timely. So I will hand it over to Dr. Rafai. Thank you.
Good morning, everyone, and thanks for joining. And I hope you enjoyed the 3 days conference here. Today, as Becky said, it's our last day here. Our first speaker for today, the keynote speaker, is Dr. Carolyn Burns. Dr. Burns is a board-certified pathologist, served as a chief of pathology department at the Jewish Hospital Healthcare System in Louisville, Kentucky, in USA, between 1991 and 2011. Dr. Burns is currently the president for SABM, Society of Advanced Blood Management. She's also an active member of several medical societies, including the Association for the Advancement of Blood and Biotherapies, College of American Pathologists, and the American Society of Clinical Pathologists. Dr. Burns is a passionate advocate for patients' blood management and blood health. She has been an invited speaker within the United States, Europe, Asia, and Africa on varied patients' blood management topics. She's also a patient's blood management advisor for numerous hospitals and industry partners around the world. With this, I will ask Dr. Barnes to join us and give her talk today. Dr. Barnes.
Great. Thanks, Majid, and thanks, Becky. It's great to be with everybody. A huge round of thank yous as well to BMSS. We've had a long-standing partnership, memorandum of understanding, and this joint session every year is just delightful, and it's a real honor to be a part. So let me share my screen, and we'll bring this up. Change the swap. Can you all see that in the screen now?
Yeah.
Great. Thank you. So I was actually very excited when the committee at BMSS asked me to talk about plasma, because many of you already know, as you've come to know me over the years, I am a self-proclaimed plasma phobe. I think plasma is probably the most misunderstood, misused, and I'll just say abused product that we have. And I think that comes from a huge lack of understanding about what is, as you can see, I have here the subtitle of what's the real deal with this yellow stuff. So what I'm going to try to walk you through is a little bit of that story, the state of the science on the efficacy, or rather the lack thereof, and the adverse outcomes that are associated with plasma transfusions. My obligatory financial relationships, I'm not going to be discussing any of that today. Please feel free to contact me either through my email, as listed at the bottom of the slide, or also you can get a hold of me through SABM. And any of you, by the way, who are not members of SABM, I would welcome you joining. So please become a part of that wonderful society. So again, my purpose is to walk through the state of the science, where we are regarding plasma, and particularly as it relates to this kind of overarching concept that we're all really pushing of blood health. I think it's important for us to understand that risk of transfusion in general, what are those principles and pillars of PBM, and emphasizing again that concept of blood health, blood as an organ. And we're going to examine pretty heavily how we weigh in with conventional coagulation testing, and that it is not at all adequate for identifying bleeding risk, which I think we all know, but we sometimes go a little bit astray when we start to look at those laboratories. And I will be discussing the adverse outcomes associated with plasma in general, but also I have a few subpopulations where we're seeing the literature really come to the forefront, and how we have to view those patients quite differently, and the lack, again, of evidence that plasma is useful. And I always hope at the end of the day that you get to take away some little pearl that you can apply to your everyday practice. So if we look just in general at the risk-benefit ratio of transfusion, I won't belabor this, but I think the bottom line is we've really tipped the scale. I can tell you this has occurred even during my tenure in my career, that I started out in the early 90s, so I'm dating myself as always, but I really did think that when we gave things like plasma and platelets, which by the way, you're going to hear Dr. Blumberg talk about platelets, the other yellow stuff, and are we really preventing or stopping bleeding? And actually, more than likely, no, because also those risks of such things as circulatory overload, acute lung injury, the number 1, number 2 causes of death associated with transfusion, are transfusion errors, sadly enough, that still may occur, sepsis that can occur because of bacterial contamination, a little less likely with plasma, but certainly a concern when we look at platelets. And their shelf life. We have systemic inflammatory response syndrome. We heard a lot about that during COVID, didn't we? But that's what happens when we transfuse. There are lots of things in that bag, not just in the case of plasma, the procoagulant factors, but all sorts of other things such as proteins, cytokines, biologic response modifiers, free radicals, etc. And this very likely leads to what we know as TRIM, transfusion-related immune modulation, where we see that dampening down or that immunosuppression when we transfuse. We also cannot neglect infectious disease. I know in the United States, in our high resource country, we test for a bevy of infectious disease states in our blood donors. However, not all countries have that available. And even within the United States, even though we are less likely to be worried here about HIV, hepatitis C, Hep B, we have to remember we have another hepatitidity on the block. The new kid is hepatitis E. 10 or so years ago, we had the onset of West Nile virus. We saw about 6 or 7 years ago surrounding the Olympics, we had Zika. We have Chagas, leishmaniasis, babesiosis, by the way, is expanding within the United States, coming out of its corridor in New England and moving ever westward and south. We have to think about chikungunya, dengue, yellow fever, Ebola. And I know, at least in the United States, our donor centers are monitoring for SARS-CoV-2. Maybe not historically, very likely, but that's what our donor centers are about, is to start to monitor these infectious diseases. And God forbid the one we don't know about. So infectious disease is still an issue. And then you can see a host of other things that happen, our delayed hemolytic transfusion reactions. Post-transfusion purpura. I've seen 2 cases of this in my career, but they were both quite significant and severe. Transfusion-associated graft versus host disease that can affect our hematology oncology patients, our neonatal patients. And of course, our chronic transfusion-dependent patients, such as our sickle cell patients, thalassemia patients, myelodysplastic patients. We have to worry about transfusion-related iron overload. So this huge plethora of adverse events associated with transfusion in general. And when we talk about plasma, it's no different. So this is where we start to incorporate, right, all the things about patient blood management, our management of anemia in the while we're optimizing coagulation. How can we do that without necessarily transfusing with plasma? That's going to be the focus here. Interdisciplinary blood conservation modalities. How do we insert things such as cell salvage, pharmaceuticals, topical hemostats, all of these things. And of course, we always do this on the most important pillar, which is patient-centered decision-making. And all of that funnels up to our improved patient outcomes. So that is, in a nutshell, our PBM, right? And this all goes toward helping blood as an organ, managing, maintaining blood health. And blood is indeed an organ by definition. And by the way, blood does a whole lot of other things than just transfer, gas exchange, etc., or in the case of plasma, provide procoagulant factors. So what we want to be looking at is harnessing the patient's own blood. I think I'm preaching to the choir here, but we want to preserve that patient's blood. We want to get in the front of it. I'd like to think of us preventing those insufficiencies or failures, so we don't necessarily even have to consider replacement of that organ. So let's get in the weeds, then we'll talk plasma. And I mentioned to you that I am a real plasmaphobe, and I'm going to tell you, I think it's with good reason. If you look, however, in your average textbook, when I go and I teach transfusion medicine, let's say to residents or medical students, etc., we go into the textbook and it will list these indications. Management of patients with congenital or acquired factor deficiencies when you don't have specific factors. And this can be a problem in low, middle resource countries, or even in the United States here, where we have very small community hospitals in rural areas. So think hemophilia. Then the second dot point here is management of bleeding patients. Notice the word bleeding patients, where you need a multitude of coagulation factors. Think liver transplant. When they are in that anhepatic phase, that's very often where we're seeing that use of plasma come into play. Now, if you were at the SABM annual meeting, you also heard from our wonderful colleague, Angel, who was presenting his data on bloodless liver transplants. So we're moving in a different direction there. We do see plasma being used as part of massive hemorrhage protocols. Most of us here, again, in the United States, look toward a more balanced hemostasis in terms of red cells, plasma, and platelets when we have the exsanguinating patient. Plasma is certainly the primary fluid that we give in replacement for patients with TTP. I am, however, seeing people stretch that out a little bit and instead intervene using albumin once they've started to get a bit of that recovery. But it is out of the gate the fluid of choice. And then if you've ever been involved with a patient such as C1 esterase protein deficiency, I had a patient during my career that sadly enough was a bit of a frequent flyer and would come into our community hospital where we did not have specific concentrates or drugs to handle her deficiency, and we at times did utilize plasma. So these are kind of the textbook indications. I think it's more important, however, to look at the contraindications. And you might laugh at the first one here, because volume expansion and nutrition are certainly not an indication for plasma. But I did have a surgeon early in my career that gave every single one of his patients 4 units of plasma post-op to expand their volume and for nutrition. I had to work pretty hard to get rid of that practice, but it ultimately worked. DIC without bleeding. Again, the operative word is without bleeding. Remember, very often DIC, especially chronic DIC, is a clotting issue, not a bleeding issue. I think now we're very much aware that reversal of vitamin K antagonist-induced bleeding is best handled with IV vitamin K and 4-factor prothrombin complex concentrates, not plasma. Now, of course, if you're in an area where you don't have access to IV vitamin K or PCCs, you may need to resort to plasma. But we would hope that this is not the general case. Therapeutic apheresis that's not associated with TTP, most often people are utilizing albumin, and plasma should not be the first fluid of choice. It's been a long time since I've ever seen one of my neonatal colleagues look to pull off the shelf plasma to prevent periventricular hemorrhage in premature neonates. But many, many years ago, this was not uncommon. But what we really see, and the most important thing I'm going to talk about today, is the biggest use of plasma. And that's in patients with mild to moderate elevations of that PT-INR, that conventional coagulation test, without bleeding. And I'm going to show you the epidemiology of this. So when we look back even in 2015, the group up at Pittsburgh led by Daryl Triulzi did a very nice study over a year where they looked in their hospitals. They had 10 of them. They had about 72,000 some plasma units to over 9,000 some patients. Now, before I even got into this paper, I'm thinking, well, I know Pittsburgh has a huge trauma center, huge transplant, huge high-risk OB, et cetera, and the biggest use of their plasma is going to be part of massive hemorrhage protocols. It was not. Notice 80%, 38% general ward, 42% ICU, 80% of plasma was utilized in those 2 arenas in non-bleeding patients with quote unquote elevated INRs. And notice that when plasma was given, 45% of it was given as 2 units, 15% as 1 unit. So when it was utilized, it wasn't dosed appropriately. The average adult dose is 3 to 4 units based on weight-based dosing and or the volume in each bag. So what we're seeing is we're using it in patients that are not bleeding, and we underdose it. And in the words of Dr. Triulzi, when he presented this paper here in Kentucky as part of our Kentucky Association of Blood Banks meeting, he basically said, you might as well open up that bag and let it run on your patient's chest for all the good that is going to do. Now, notice also that only around 42% of the patients that received the plasma had their INR go below 1.6. That was if they repeated the INR. Because very often what happens is we react to the INR, we treat, quote unquote, the INR, and we don't bother to see if it did what we hoped it was going to do. In other words, push that lab value down. And notice they're using 1.6. But this study, basically the epidemiology shows that we have non-evidence-based plasma use. We use it inappropriately in patients that are not bleeding. And when we use it, we just give a teeny bit and we think we're going to do goodness. And there's more. Another study that looked at plasma use, just over 1/4. Notice almost 50% were against their own internal guidelines. Over 1/3 of those that were given were non-bleeding, that magical, in other words, other category. So we're still seeing this misuse of plasma. A Canadian study over 1 year, again, 11,000 some units, over 1/3 had no indication given. And 2/3 of those were given to non-bleeding patients, even though they weren't going to have any planned procedure. And they had an elevated INR, the majority, and they're choosing their number at 1.8, which I will tell you as we go forward, that's at least a little more accessible than using a 1.6 or the magical 1.5. So we can ask ourselves then, why are we doing this? Why are we giving plasma inappropriately outside of the hemorrhaging patient, or perhaps that patient with TTP? And I think it's because we make some assumptions. And this first assumption, as put forth in Dr. Paul Mintz's textbook many years ago, which is kind of my Bible, he talks about the fact that abnormal coagulation studies absolutely do not predict bleeding risk. I think we all know that in our heart of hearts. But there's a little bit of an issue when we are particularly in the intensive care unit, and we've gotten that blue top tube, and now we're presented with that PT INR, and it's outside the normal reference range. So we start to say, well, let's go down road number 2 here. That maybe if I go ahead and I transfuse plasma, particularly if my patient's going to go for a procedure, then that's going to help me correct this hemostatic abnormality. And notice my word in front of that is presumed. So now I've gone from assumption number 1 to presumption number 2. And then I think, well, and I think we all as providers, we want to be proactive. We want to help our patients, right? So we go down road number 3 and we provide prophylactic plasma because we think that's going to help, as opposed to waiting to provide it perhaps therapeutically. And I'll just say this, as the wise person once said, sometimes the road less traveled is less traveled for a reason. But we go down the road. So let's talk about that INR a little bit. And if you don't get anything out of today, I want you to understand these key concepts, because I think it's going to completely change the way you view conventional coagulation testing, and ergo where you would want to go perhaps with plasma. This is my slide that does the, what is the INR, what is it not, what can it do, but what can it not do? So let's just ratchet back a little bit and talk about that INR, the International Normalized Ratio. Basically, the INR is a mathematical calculation to standardize the pro-time results between different laboratories. Because laboratories around the world, we all have different instruments, we have different reagents, we set our normal reference ranges based on our own demographic in our own population. And that's what we're required to do. So if you look at a pro-time, and therefore an INR, what we do in the laboratory is we take our instrument and we get 50 people that are otherwise healthy on no medications that would disrupt that test. So we're going to get 50 people, draw a blue top tube, do a pro-time, calculate the INR, and what do we always get? That beautiful bell-shaped Gaussian curve. And we snip that Gaussian curve, that bell, at -2 and +2 standard deviations. We throw away the -3s, toss away the +3s, and that is our normal reference range. And so the INR, normal reference range, ends up being somewhere between 0.9 to 1.2, maybe 0.9 to 1.3. I've seen a lab that's had a 1.0 to 1.3. Now, keep in mind, the real need for the INR was to standardize the therapeutic range of vitamin K antagonists, warfarin. There's really more importance in the therapeutic range of our INR when we dose our patients. So now we have a standardized way of looking at the pro-time. So we are knowing exactly, is our patient subtherapeutic, therapeutic, or supratherapeutic? That was the intent of the INR. But because we're required to have that normal reference range, now it's out there, right? And now anytime you get an INR on a patient that's not on warfarin or another vitamin K antagonist, we feel compelled to react to it. But if you look at in the backdrop of a study that was done, it's the top one on the left. This is whole blood donors that went in, otherwise healthy people living their lives, right? And they go in and they donate their whole blood, and a plasma unit is derived from that. And at the time of donation, that lovely blue top tube is drawn, and this group looked at the INR ranges of normal, healthy whole blood donors. And there were some, by the way, that were below 0.9, some that were up as high as 1.6. So I'm going to ask the ridiculous question, the very ridiculous rhetorical question. So is that person, that's 0.8 among this otherwise healthy donor pool, going to clot? And was that person who had maybe an INR of 1.4 going to bleed? And of course, no to both of those questions. So it shows us once again the INR's intent. What is it? What is it not? And better yet, this study went on to show as well that when you take people and you have an INR that is outside that reference range, particularly if it's below 1.7, you can give plasma till the cows come home and you will not budge the number. Notice the graph on the right, it's curvilinear. You get that decrease in INR for a certain period of time. And then when you get to be at about 20 to 25, maybe 30% of factor activity, you have sufficient factor activity to maintain hemostasis and you start to flatline. And you're not going to change the number. So this also tells us that what's in the bag of plasma? All bags of plasma are not created equal. Plasma from me will have different factor level activities, albeit I'm healthy, but I might be walking around with factor level activities of 50 to 75%, perfectly normal. But Becky might go and donate her plasma, and her factor activity, if it were quantified, would be maybe 100 to 125% activity. So what's in the bag, by the way, your donor centers are not quantifying or even qualifying each and every factor in that bag. The only product that actually quantifies a minimum standard is solvent detergent plasma. So the bulk of our plasma is coming from whole blood donors, otherwise healthy. We don't know what their INR is walking around on a daily basis, and we don't know what their factor level activity is, which results in the bag. We're assuming it's adequate. So those 4 bags of plasma you give are not created equal. So all of this, once again, proves what the INR is, what it's not, what it can do for us, and what it can't do. And if you look at this again, as we've seen in 2 different institutions, I mentioned in the Triolzi study that only 40-some% actually, quote unquote, normalized their INR. For their normal, that was below 1.6. Notice in these 2 different studies, 12% actually normalized. And then the study on the right, only 7.5-some%. And notice also in that second study, what happened in those patients, it delayed their procedure. And they also had almost a 6% reaction rate for both Taco and Trally. So we're not doing our patients necessarily any favors by delaying procedures, having these adverse outcomes, and normalizing an INR is not necessarily the point of the endeavor. So implementing change, we've seen 2 institutions do this. Both University of Texas Southwestern have published, as well as Rhode Island. Excellent educational opportunities that now 2.0 is the new 1.5. And no harm to patients, no increases in bleeding, no increases in mortality rate when we use less plasma and we avoid plasma for that magical 1.5. By the way, as an offshoot, I've always wondered where we came up with that magical 1.5. Why isn't it 1.4 or why 1.6? I've never seen the definitive article and I would love to know. I think personally the 1.5 came from many, many years ago, when in the laboratory, we defined an abnormal protime as 1.5 times the upper limit of the normal reference range. So maybe it's a bit of a shame on us in the laboratory that we failed to really educate around what the INR was intended to be for therapeutic purposes and not as a predictor of bleeding. But it does show you, and if you believe in the graph from the prior slide, then that's going to tell you as well that really it might be 1.7 or 1.8 or even as high as 2.0. So I think also this makes us beg the question, when you have a patient, let's say in the intensive care unit, and their INR is elevated outside that normal reference range, and you're not using that INR because they are on a vitamin K antagonist, why is it high? We have to ask the 50 whys. And this group actually did that. And they looked at all of their patients that had INRs greater than 1.5. And they did factor activities, anticoagulant factor activities, D-dimers, et cetera. The most common pattern was vitamin K deficiency. Patients can become vitamin K deficient very quickly when they're in the intensive care unit. Liver disease was the second most common. I can tell you that was very common in my facility because we had a large end-stage liver disease program and transplant program. Third most common was residual direct oral anticoagulants. There are a ton of patients now out there on our 10A inhibitors. None of these specimens showed evidence of DIC. So ask why. And if vitamin K deficiency and liver disease are number 1 and number 2, we might be able to treat that abnormal INR, I'm using that word loosely, with IV vitamin K and not reach for plasma. So I'll be fair, however, let's just, again, kind of go back a little bit in the literature. It really wasn't until 2010 that we saw any evidence-based plasma transfusion literature that came to the fore. And in this particular study on the left, this group got together and used the grade method, and they looked at many different clinical scenarios as listed there. And at that time in 2010, they really found that the evidence showed that plasma was useful as part of a massive hemorrhage protocol. We need to give a little yellow when we're giving red. And also in the event of warfarin-induced intracranial hemorrhage. Now think 2010, this is before PCCs came to the market. Fast forward to 2012, 21 trials were reviewed by this particular group. They did not include trauma hemorrhage. And you can see their conclusions based on their systematic review was that none of these situations found that plasma was useful. So we're starting to see the kernels of this lack of evidence being placed out in there into the world. Another institution in 2016 looked at their 1,200 some patients that were non-cardiac surgery pre-op, non-bleeding, INRs greater than the magical 1.5. 11 some percent received prophylactic plasma, and over 50% of those that received the plasma transfusion had grade 3 bleeds compared to 30 some percent that received none. So once again, more conservative plasma transfusion in those that are non-bleeding. Our friends at Mayo looked at over 3,300 of their patients, and they did evaluate when you transfuse high volumes of plasma, you are going to result in that reduced INR. Think that graph. When it's very high, you're going to bring it down. But then it goes from curvilinear to linear. And they point out at the expense of increased length of stay, increased adverse events. They did a similar finding in their subgroup of cardiovascular surgery patients. Same thing. So once again, are we helping or are we harming? Intraoperative plasma volumes and outcomes in cardiac surgery, in particular, 2020, single academic hospital, higher transfusion volumes associated with adverse outcomes, and in a dose-dependent manner. We are mirror image now to what we see with red cells and with platelets. So every unit we give can cause adverse outcomes. Our neurosurgical and neurocrit care friends and colleagues always worry, yes, of course. When you have bleeding in the head, small space bleeding is bad. But in multiple studies that have been done, we see that when you have an INR of around 1.7, there are adequate hemostatic factors. Think about that graph on the previous slide. And even in patients with traumatic brain injury, we have poorer outcomes in those patients when we transfuse plasma, delayed time to the intervention, increased morbidity and mortality. And the most recent literature really points that the use of plasma for TBI-induced coagulopathy is not supported. So I think we've got evidence now to start thinking about even these patient populations. Spine surgery, 6,900 some patients over 7 years. 50% received plasma for INR less than 1.7. And there were increased infections, length of stay, ischemic respiratory, renal, and thrombotic complications. Again, we're mirroring what we see with red blood cells. So this plasma transfusion and outcomes in a nutshell: increased infections, increased multi-organ failure, ARDS. We do see higher rates of TACO with plasma-containing components because how do we deliver it? as fast as the patient can tolerate. So we fluid overload. TRALI, acute lung injury, severe allergic and anaphylactic reactions. I can tell you I saw many of these at my institution because we were using a lot of plasma in our VAD and ECMO patients. And perhaps we should have rethought our strategy. Increased morbidity again in oncologic spine surgery, and once again in that dose-dependent manner. And the citations are to your right. The TOPIC trial was one of the first and only randomized controlled trials that we've seen over the last several years. And this is a small study, but I think it's important because it's exactly in the patient population that we're talking about. Patients with mild to moderate elevations, even higher, 3.0 of their INR, going for minimally invasive interventions, and notice that those that received the prophylactic plasma did not have better outcomes than those that received none. Again, our friends up with Jeffrey Carson in New Jersey, they did a pilot study as well, 57 non-bleeding patients, and notice almost 2/3 of them are with cirrhosis. So it points to, again, why the high INR in our critical care patients. Plasma was dosed a little lower because these patients cannot tolerate fluid, and the plasma group really didn't have any differences in terms of bleeding. And also noticed that they didn't really budge the number. So once again, we're not moving the needle on the lab. And that's not what we're treating anyway. We want to treat our patients. For interventional radiology, our Mayo friends, again, looked at their retrospective patients over a 4-year period. The 1,800 patients that had the INR greater than or equal to 1.5, almost 10% received plasma. No differences in outcomes except that those patients that received plasma actually landed in the ICU more frequently. Our end-stage liver disease patients, let's focus on that as a subgroup. Very nice guidelines now, even in the backdrop of interventions on the GI tract, that we can allow these patients, because of their rebalanced hemostasis. Remember, end-stage liver disease patients, their liver is just as bad, making anticoagulant factors as procoagulant factors. And they actually have an increase in von Willebrand factor as an acute phase marker. So they have normal, if not heightened, thrombin generation. So they have a rebalanced hemostasis. We heard about that at the SABM annual meeting. And it is true if you look at your liver disease patients. So recommending an INR not be an indication for plasma transfusion if it's at 2.5 or less. Maybe if it's higher than that, think about, again, IV vitamin K and a lower dose of plasma if absolutely necessary, watching their volume. The end-stage liver disease and INR values as recommended from the AGA, they really recommend against the use of that because the INR, again, is not predictive of bleeding in these patients. And actually, if you talk to your liver transplant folks, they'll tell you they worry more about clotting. My liver transplant surgeons certainly did. They also in the AGA recommend viscoelastic testing. I've seen many, many times that the INR is very high, but when you get a viscoelastic test such as TEG, Quantra, ROTEM, you will see a normal pattern on VET. The British Society of Hematology came out in 2018, a very hard and fast, that particularly when INR is between 1.5 and 1.8, plasma is not supported by good evidence. So again, think about that curvy linear relationship. Think about what the INR is, what it is not, what it can do, and what it cannot do. Now, I'll just bring up one thing very quickly about the cost of plasma, because it's not infrequent that I am working with a facility, and many of the docs, particularly when we're talking about, anticoagulant reversal. They'll say, well, Carolyn, prothrombin complex concentrates are pricey. In my demographic here in Kentucky, it's roughly for the lowest dose around $2,200. Now I say, so Carolyn, plasma's cheap. And I'll say, well, plasma really isn't cheap. First off, we can't cheapen the adverse outcomes associated with it, right? But also, let's just talk the dollars. And when you look at activity-based costing of plasma, plasma was found by the same group that did this for red cells and platelets. Plasma, a single unit, was found to be 10 times higher than the acquisition cost. So I point out to my clinicians here that in my demographic, plasma per bag is $50 a bag. An adult dose, 4 bags. We're going to do the math. 50 times 4, 200 times 10 with the activity-based cost, that direct and indirect cost analysis, which doesn't include the cost of the adverse outcome. So now we're talking $2,000. So it's at least equivalent to PCC, which is going to reduce your INR and your bleeding faster. And most often, if you look at the amount of plasma you need to give to override and change that INR, it's not just the 1 dose, it's 2 or 3. So now we're talking $4,000 or potentially $6,000. So plasma is not cheap. We have to look at it differently. So I'm going to end here with a beautiful visual that comes again from Paul Mintz's textbook. And I think it gives a really good view of where we are, even with platelets, by the way, that again, Neil's going to talk about, and our INR. And I think it really helps to elucidate and focus on, we aren't in the hot zone where we really need to think about plasma transfusion. We can consider other things until our INR is very high. So just a nice way to kind of capture that and maybe round out this discussion. So I will stop there. Thank you so much. And I look forward to hearing the rest of the discussions this morning, the sessions. Thank you to BMSS and everyone that was on the planning committee for inviting Savin to participate in this. We always enjoy being a part of the conference. So thanks very much. And I'll wait questions.
Thank you very much, Dr. Burns. It's a great talk. Everybody agreed, but everybody cannot do anything about it. So sorry to say this. So now I'm going to present our next speaker for this morning. He's my boss, so I'm going to behave as much as I can. I can promise. Dr. Neil Blumberg. So Dr. Blumberg is the director of the Transfusion Medicine and Blood Bank Unit at the University of Rochester, Rochester, New York. He received his medical degree and residency training in laboratory medicine, hematology, and blood banking at Yale University, New Haven, Connecticut, in USA. His particular interest is in transfusion immunomodulation, and his clinical interests are also in the diagnosis and treatment of immune disorders such as autoimmune hemolytic anemia, autoimmune thrombocytopenia, stem cells, and mitigating transfusion side effect through the leukoreduction of the sterile products, and removed any stored supernatant through washing of these sterile products as well. With this, I'm going to stop here and give the mic to Dr. Blumberg.
Thank you, Majid. And thank you to the Bloodless Medicine and Surgery Society and SABM for inviting me to talk today. I know the subject of the meeting has been compassion, and I'm not going to spend any time talking about it, although it's compassionate to only give patients treatments that we know actually are efficacious and have a net benefit. And platelet transfusion, as you've heard about plasma transfusion from Dr. Burns, and as we've now found out over the last 20 years from many randomized trials, red cells, we've overly estimated the benefit of transfusion, and we've underestimated the harm. One of the topics I'm going to talk about is the ABO blood group system, which you've all heard about, but I will probably talk about it in ways you might not have heard about it before, because I think our approach to ABO, which is a long tradition, has probably contributed to the harms that Dr. Burns mentioned with plasma and with platelets for sure. And I will talk about that near the end of my talk. So you often see these platelet transfusion guidelines. I will say, obviously, this is only relevant for patients who accept transfusion. Since we have a fair number of patients and a fair number of who don't want to use transfusion for one reason or the other, this may not have direct relevance, but as a hematologist and watching over the decades how, for example, stem cell transplant has been used, we know from the work of people like Dr. Patricia Ford in Philadelphia that we can do certain types of transplants without transfusion. But there are transplants that most physicians, and I think even Dr. Ford, would not do, which are the allo transplants from other donors. And that's because these patients have sufficiently high levels of complication from the drugs and from the transplant that they almost all require transfusion by standard approaches. And actually, one of the few areas of medicine where transfusion has been shown in randomized trials to be of benefit to patients, we have pretty much no trials showing that for red cells and no trials for plasma cryoprecipitate. But for platelets, we have randomized trials that suggest that if you transfuse patients prophylactically, in other words, they're not bleeding, at counts of less than 10,000, that you will have significantly less bleeding during the course of their treatment. These are almost all patients with hematologic malignancies, such as acute myeloid leukemia or undergoing stem cell transplant. Now, we don't know what the long-term effects of these transfusion are, but bleeding, obviously, we'll all agree, is both potentially dangerous for patients, but also exceedingly upsetting to everyone, the patient, their family, the nurses, and even the doctors who may only be there for 10 or 15 or 20 minutes a day. So bleeding is something we don't want to see. Now, if we could come up with drugs that were better at treating these hematologic malignancies without causing these periods of prolonged thrombocytopenia and anemia, this would not be an issue. But we're not there yet. We're still treating acute myeloid leukemia pretty much, at least during the initial induction therapy, the same way now, with not a lot of differences than when I was in training 40 years ago. So this is the major use, and it is evidence-based. But all these other guidelines, which are basically, as I tell my residents and other trainees and technologists, are based on a bunch of people eating tuna fish sandwiches saying, what do you think? These are the numbers they came up with. And they're not unreasonable, but there's no evidence for them. And in fact, I'll show you that there's some evidence that we're doing harm with these numerical guidelines, because we know that, and most hematologists certainly know this, that the platelet count per se is not a particularly good predictor of clinical bleeding. It has its role in understanding what's going on, but you'll see patients with, for example, immune thrombocytopenia with counts of 1,000 or 2,000. They're not bleeding, and you'll see patients with counts of 30,000, who have widespread mucositis and toxic effects of drugs, and they're bleeding. So platelet count is not a terrific single predictor of what we should be doing. And there are the usual side effects of transfusion. You'll find these in any textbook that you look at, but what you won't find in hematology or transfusion medicine textbooks is what I'm going to talk about next. So prophylactic transfusion is in non-bleeding patients. Therapeutic platelet transfusion is in patients who are bleeding and have some reason to think that platelets play a role. So there's no question that prophylactic transfusions work. And in general, they make the patient feel better in the sense that they don't have to look at blood coming out of their nose or in their urinary tract. But as far as we know, probably do not affect mortality, but it may be that we just don't have large enough studies. But it turns out that bleeding is actually a rather uncommon cause of death in modern hospitals in many places in the world. And in fact, the real problem is that patients die of infection, sepsis, thrombosis, whether arterial or venous. And in fact, transfusion plays a role in that. So in general, we don't need to give a lot of platelets. We don't need to give them at higher platelet counts. And in fact, there may be reason to minimize this. In our own center, when we looked at the rate of disease recurrence and death due to hematologic malignancies, there was a strong dose effect that as we were giving more platelets for various reasons, there was an association. This is not a randomized trial. There was an association. The more platelets we gave them during induction therapy, the worse the prognosis. So a minimal approach, minimizing transfusion might be a good idea. And in fact, there are several studies looking at dose, suggesting that dose doesn't matter very much in general. But there are some problems, and these have become particularly evident in the last, let's say, 10 to 15 years. Turns out that platelets stored in the blood bank are not normal, healthy platelets. They're in a toxic stew of inflammatory cytokines in the supernatant. The platelets are highly activated, and maybe that's why they provide some benefit. But in fact, they also clearly, both in the laboratory, experimental animals, and in patients, predispose to inflammation. And this is manifested in modest clinical importance, things like rigors and fever, and that in fact they may increase bleeding. And there are now 3 randomized trials that suggest that platelet transfusions, for example, in patients with antiplatelet drugs who have head bleeds, there's a substantial increase in mortality and bleeding. And this was in the Lancet about 7 years ago. Premature newborns who receive prophylactic transfusions to prevent bleeding. The liberal arm of the study had a much higher rate. Whoops, sorry about that. The liberal arm of the study had substantially higher bleeding and mortality than the restrictive arm, using 25,000 versus 50,000 as the prophylactic threshold. And there's a rather unusual study where platelet transfusion was being used at very high doses to, at least theoretically, close a foramen ovale open at the time of birth. And in fact, they had a 10-fold increase in intracranial bleeding in the patients who got platelets. So this is not good news. What we're doing is causing harm. And this has caused a lot of upset and even a little disbelief, because longstanding clinical practices, we're doing some good. And in fact, we're doing some harm, and substantial harm, including mortality. So what are the alternatives? Well, some things that should be used before platelet transfusion in most clinical settings are tranexamic acid, an antifibrinolytic that I think has been discussed at this meeting. There's also some evidence that arginine vasopressin, the artificial vasopressin analog, also known as DDAVP, may in fact reduce bleeding and thrombosis in trauma patients and in cardiac surgery. One of the advantages is very important of tranexamic acid and DDAVP is, 1, they have very few side effects, and 2, they are absolutely dirt cheap and may be affordable even in limited resource settings. And so these are things that, unless there are contraindications, and there really are no contraindications to tranexamic acid, there are some to DDAVP. Mainly, you don't want to give it to patients who are volume overloaded or hypo, have low sodiums. But these are relatively minor contraindications. So what about platelet transfusion reactions? We've known about some of these for a long, long time. And it's been known from work from a variety of groups that the supernatant platelet transfusions contain all sorts of inflammatory cytokines. And this may, in fact, account for some of these fever and rigor reactions. But what has also been found is that platelets provide other cytokines that are inflammatory mediators. And that these platelet storage solutions, when we give them to animals, when we give them to patients, there is actually a relationship that if you look at the amount of cytokines present, that as you get into the highest 20%, the fifth quintile, the percent of transfusion with reactions goes up by 5 to 6-fold. It gets a little bit worse when we start looking at the other thing. In hematology, when we give treatments to patients that are pro-hemostatic, examples might be factor VIII for hemophilia, Kcentra, or Beriplex, the 2, 7, 9, 10 complex, that these have as their main side effect is they work for hemostasis, but they also can predispose to thrombosis. Patients with hemophilia, for example, who get very, very high levels of factor VIII will have an increased risk. Fortunately, not terribly common, but they will have an increased risk of stroke and heart attack and deep vein thrombosis. So platelets probably have the same sort of risks. There have been some case reports from a few years ago of stent thromboses and coronary disease fairly soon after a platelet transfusion. And so in looking at this, Ala Karana, who some of you may know from his work on cancer thrombosis, led a study in which our group examined the rate of thrombosis after platelet transfusions. And this is an epidemiologic study. And it turns out that platelet transfusion, as you would expect, perhaps, was independently associated with both arterial and venous thromboses. And in fact, this led to mortality. Now, whether this is a cause and effect, you could argue, because this is not a randomized trial. But it was certainly the canary in the mine shaft for me, thinking about platelet transfusions and thrombosis. So we looked at our experience here in prophylactic platelet transfusion prior to mostly radiological interventional procedures. It was mostly line placements. And as you can see, these patients were not terribly, these are moderate, from a hematologist standpoint, these are moderate levels of thrombocytopenia, perhaps not for the surgeon. So we looked at several hundred patients, and what we found is in the week after these platelet transfusions procedures, the thrombosis rate was 5%, which is, about 20 times the level that are seen in hospitalizations overall. And in fact, most of these patients had cancer. There were also a mortality rate of 16%, which was very similar to a group of patients that Darrell Core studied at the Mayo Clinic. So these prophylactic transfusions, we're not attributing all of this mortality to transfusions. These are patients with very serious diseases, but there's some relationship here that's going on, and it's very worrisome. So we conclude that platelet transfusions are associated with thrombosis in a wide variety of clinical settings, and that some degree of causality is likely. And we know that while they provide some hemostatic benefit, they're also providing inflammation, and inflammation is also linked to thrombosis in animal model and clinical data. So that it may be in many situations, before reaching for a platelet transfusion, one should consider other agents that have been shown in randomized trials to be effective at preventing or treating bleeding, such as tranexamic acid and DDAVP. So I'm going to shift gears here to talk about something which you won't read about in any textbook or very few review articles, although there's growing literature on the subject. Our understanding in blood banking of what the ABO blood group goes back, over 120 years to Karl Landsteiner, and certain ideas came into popularity. And Dr. Rafai led a group writing a study, or I should say a commentary, on the notion of compatible blood products and universal donor blood products. And there's good news and bad news here. The bad news is we got this wrong. The good news is it's not going to be that difficult to fix if we find the will. And we have done this over the last 30 or 40 years in Rochester, because we have slowly begun to recognize that our old patterns of practice were harming patients. So we don't want to, in general, in immunology, if you're a rheumatologist, you don't want to give people drugs to which they have antibodies. And you don't want to give antibodies to the people who have the antigen. And the same thing's true with organ transplant, with rare exception. You don't want to give a group A kidney in general to a group O recipient. And we've been doing this with blood for a long time. We've been using AB plasma, which is incompatible with the antibodies present in 95% of recipients. We've been doing that forever. And these antigens are, for better or worse, present on pretty much every cell in the body, and there are soluble forms in plasma, either from cells that are falling apart and becoming senescent, or because they're actively secreted. And so these are ubiquitous antigens. So we can go back a long, long time to two randomized trials looking at a hematologically important problem, which is patients who become unresponsive to platelet transfusions. And this is a big problem, as I mentioned, if you're worried about bleeding, because if you can't raise the platelet count over 10,000, you have a dramatic increase in the risk of bleeding. This is called platelet refractoriness. And so these are two small randomized trials. This one came from Robert Carr and his associates in the north of England. And they actually intentionally transfused major mismatch. In other words, giving a group B platelet to a group O recipient or a recipient. And what they found was that the refractoriness rate was 10 times higher, basically giving ABO major incompatible platelets. And these patients also made more HLA antibodies. These are the antibodies that are responsible for refractoriness. We did a very similar trial, except it was a little bit different design. We just did what most places did, which was which is transfuse whatever is about to outdate without regard to ABO. And as recently as this year, the American Society of Hematology had an educational program that stated emphatically that ABO doesn't matter for platelets, which is 100% wrong. And we have the randomized trial data that's 30 years plus old to show it. And in fact, this is what happens to platelet count increments when you give ABO incompatible platelets. The first transfusion or two, not a problem, then it starts going down. And if you give plasma incompatible, minor incompatible, such as a group O platelet to an A recipient, you can start seeing poorer results with the first or second transfusion. But if you give ABO identical platelets, as we did in this randomized trial, the counts actually get a little bit better with subsequent transfusions. They certainly don't get worse. And this was work led by my wife and collaborator, Dr. Joanna Heel. So what's going on here in terms of platelet function? Because we're just talking about platelet numbers. So Dr. Rafai did a study that was published about 10 years ago, showing that as you expose group A platelets to O plasma, terrible things happen to the ability of these platelets to aggregate. If you get a very high titer antibody here, you get almost no platelet aggregation. So giving high titer group O platelets to A recipients is probably not a good idea. If you give very, very low titer, like maybe 1 to 60, you may in fact be in better shape. And so this may explain one of the reasons why group O whole blood, that's low titer, is safer than component therapy. Because in component therapy, we're giving blood components that are incompatible with 100% of patients in general. And this is also work from Majid's laboratory showing that ABO immune complexes interfere with the MA and to a lesser extent the R time and certainly the alpha angle in thromboelastography. And I'm about to finish. There's some very interesting work that was just published in Blood a couple of years ago from David Rowe, who's a neurologist at Columbia University. And they looked at patients who had intracranial hemorrhages and who had been taking in antiplatelet drugs. And the standard therapy is to platelet transfuse these patients. And they looked at the results with ABO incompatible versus ABO compatible, mostly identical platelet transfusions. And they found, as you would expect, crappy platelet count increments in this group, but worse yet, they had increased mortality and poor neurologic status, and the number needed to harm was 5. And so this is a typical example of what happened in the data. The mortality rate was in fact more than twofold, and poor neurologic outcomes was 15% higher. Just as a sort of final note, that the stuff that's in the supernatant of stored platelets is immunologically damaging to patients. And we have found in a randomized trial, and this is just the follow-up study, that if we wash these platelets and remove the supernatant, we can improve survival in younger lower risk patients. So in conclusion, platelet transfusions increase morbidity and mortality in many clinical settings. This may have to do with the blood transfusion services approach to the ABO blood group, at least in part. They're pro-inflammatory and pro-thrombotic, and that leukoreduction and washing mitigate these effects. And that the only evidence of any transfusion actually helping patients is, in fact, these prophylactic platelet transfusions at counts of less than 10,000. Otherwise, there's no randomized trial data to show that transfusions actually help patients. And these prophylactic transfusions before surgery or procedures may be doing more harm than good, and that the ABO blood group turns out to be a lot more important than we thought. And that, in fact, giving ABO major incompatible platelets is probably worse than doing nothing. And I leave you with the notion that we need to believe the data, not the dogma. These are over the last 40 plus years, some of my most important collaborators, and I'll stop there.
Thank you, Dr. Blumberg. I saw my name on your list. I just want to say I've been here for the last 40 years, not 40. I'm just kidding. So
it feels like 40. That's
so our next speaker for today is Dr. Erin Soydam. I hope I'm saying this right. I'm sorry if I'm not. Dr. Soydam is a trauma acute care surgical critical care attending surgeon at Allegheny Health Network in Pittsburgh, Pennsylvania, USA. She's also the medical director of the Patient's Blood Management and Bloodless Medicine program at Allegheny Health Network as well. Dr. Soydam is assistant professor at the Department of Surgery, Drexel University College of Medicine, and medical student surgical clerkship co-director. She trained in general surgery at the Medical College of Georgia in Augusta, Georgia in USA, and in surgical critical care at the University of Hawaii in Honolulu, Hawaii, USA. She has been in practice for almost 10 years. Dr. Soydam, please, you can take the mic right now. Thank you.
Get my slides here. All right, good morning. My task today is to speak a bit about massive hemorrhage protocol in bloodless medicine patients. I'm very happy to join the conference. Thank you for the kind introduction. I don't have any disclosures. So the objectives I wanted to touch on today as we approach massive hemorrhage in a bloodless patient is to first identify patients with massive hemorrhage and understand how important it is to act early in these patients. Learn strategies to stop the bleeding, and determine risks to a bleeding patient's blood health, including anemia and coagulopathy, and discuss how to treat those problems. So the first part of massive hemorrhage that's crucial is to identify it, because to arrest the hemorrhage early is crucial to have a good result. So we're going to talk about the goals of hemorrhage control, including identifying massive hemorrhage, and then identify strategies to be prepared. So to know when you receive a patient like this, you're going to be ready to take action to reduce blood loss, to optimize anemia, to manage coagulopathy. And then usually this is done through a protocol. We all hear about massive transfusion protocol, or as we like to call it now, massive hemorrhage protocol, to focus on the hemorrhage. And it's important in any protocol to make sure that your system is auditing your process and making sure that it's working at its best. So to identify massive hemorrhage, it's important to recognize shock. And going back to kind of our basics of shock, we know that by the time a patient's hypotensive, they've lost quite a bit of blood. So we want to be attuned to things like altered mental status, tachycardia, things that show us that the patient's in trouble. And so we can identify our suspicion for massive hemorrhage early, and then early activation of a protocol is important to start the steps that we can take to have the best outcome possible. And we know this is associated with decrease in mortality and overall reduction in blood products. So if you are using blood products to resuscitate a patient, if you act early and start early, overall, you'll be able to use less blood. So to have indications for a massive hemorrhage protocol activation, we use the ABC score, or the assessment of blood consumption score. Different protocols have different indications, but things you want to take into account are the mechanism of injury, the severity of injury, the patient's hemodynamics, obvious evidence of active bleeding. But it's important to remember that we're not very good at predicting this. A clinical gestalt is a poor predictor. So overall, you want to have kind of a high suspicion and probably overactivate so that you're prepared for the patients who get by you and you don't necessarily think they're in trouble. You don't want to get too far behind. So that ABC, or assessment of blood consumption score, is 2 or more of the following: tachycardia greater than 120, a systolic pressure less than 90, a positive FAST exam or ultrasound exam looking for retroperitoneal or peritoneal blood, or penetrating torso trauma. So 2 or more of those would be an indication to activate a massive hemorrhage protocol. But also, if you feel that the patient is persistently hemodynamically unstable, if you know that the patient has active bleeding that's going to require the OR or interventional radiology, that could be an indication. And if you start transfusing the patient and see that they're going to need great volume of transfusion, then that would be an indication. Obviously, for this talk, we're going to focus on not transfusing and the other things we can do in a bloodless patient. So things to consider are often an individual choice in bloodless patients. Often in trauma, you may not know that your patient's bloodless, or you may not know what they accept and don't accept. But if you do have the luxury of knowing a patient's wishes, you can see if the patient is amenable to cryoprecipitate or any albumin-containing human-derived clotting factors. So things that may be options include cryoprecipitate. We do know that all of the blood products have some cryo, but when a patient really has a fibrinogen deficiency, you want to focus on concentrated cryoprecipitate. There is also fibrinogen concentrate that you may have available to you, or von Willebrand factor is going to be corrected with cryo as well. Dr. Bloomberg mentioned DDAVP. This is something we do use in trauma, both for traumatic platelet dysfunction and uremic bleeding. This will also help activate platelets by releasing von Willebrand factor. We can potentially use prothrombin complex concentrates, which will also help activate patients' clotting factors without giving the patient plasma potentially. Or we also use FIBA at our institution, which is a 3-factor complex concentrate. Vitamin K is an option, and particularly you can keep in mind that patients who may have been on antibiotics or have biliary disease may not have adequate stores of vitamin K. And then TXA, or antifibrinolytic therapy, is an option, as well as autologous blood collection and administration. So we'll talk some about cell salvage and giving the patient's own blood back if that's something that they accept. So after you identify and activate a massive hemorrhage protocol, the key tenets of how to proceed are to stop the bleeding. So we do work closely with our pre-hospital staff for pre-hospital interventions, and things that we want to make sure that they have in mind are to avoid a lot of crystalloid fluid. This will dilute clotting factors and also potentially lead to acidosis. We'll talk about how acidosis worsens your coagulopathy. We also accept permissive hypotension. So in a patient who's actively bleeding, we allow their blood pressure to be on the lower side to reduce that pressure head of further blood loss. Typically, if a patient is alert, then they're perfusing well enough. So we usually accept lower blood pressures as long as the patient has signs of good perfusion. And then we have a program in the United States that's run through the American College of Surgeons called Stop the Bleed. You may have heard about this training. We've provided it to a lot of schools, police officers, businesses, community outreach type programs. But the tenets of it are to apply direct pressure to bleeding, to use tourniquets for extremity bleeding, and to use things like kaolin-based dressings or treated wound packing that can also help with hemostasis. So we provide some materials to folks in the community and this education to try to be able to act in sort of a mass casualty event. It's important to get the patient to a trauma center promptly. And we also do use TXA in the pre-hospital setting. So once the patient makes it to the trauma center, things that we're going to focus on is expedient movement to the operating room or to interventional radiology. And things we're going to consider in the operating room, depending on the patient's stability, are potentially minimally invasive techniques. If the patient has adequate hemodynamics, we may start with laparoscopy, minimally invasive surgery to try to reduce blood loss. But often in the case of massive hemorrhage, this won't be an option, and we're going to focus on damage control surgery. So the idea is to address bleeding, address any contamination from bowel injuries, and do only what you need to do in that first operation to get the patient out of the OR for adequate resuscitation and correction of coagulopathy, usually in the ICU. So you may break up a complex operation into steps and only do the first step at the first operation, which may include a lot of packing for hemostasis. And then another thing to consider is using cell salvage. So we're particularly lucky to have perfusionists available 24/7 at our institution. So we have cell salvage available immediately. So even in an emergent case, we can set up the cell saver and collect autologous blood. Other things to consider intraoperatively, we have a lot of hemostatic agents. We've got kind of our box of tools that we can try for hemostasis. You see them listed there. And obviously, we would hope that surgeons have meticulous technique in every case to have the best hemostasis possible. Also using, suture, electrocautery, coagulation, bipolar, things like this. So I'm sure you've heard through SABM our shift toward this focus on blood health, and things that we can do to keep the patient's blood healthy is to stop them bleeding, treat their anemia and recognize their anemia early. And that includes preventing worsening anemia with iatrogenic measures like excess lab draws. And we want to treat anemia as an independent diagnosis and disease. And as mentioned there, after we recognize it, we want to treat it just like you address diabetes and hypertension and every other problem on the patient's problem list. You want to make sure anemia is on there. We know that iatrogenic anemia is a real problem, and this is often the focus of caring for bloodless patients, but this obviously would benefit all of our patients, which is not to draw labs that they don't need. So if the blood work is not going to affect your management of the patient, it's important not to get it and to make the patient more anemic. So this is something that's also been spearheaded by the American Board of Internal Medicine and Family Practice in the US in a campaign called Choosing Wisely, which is often eliminating unnecessary testing and procedures that could subject the patient to harm and not help the patient at all. So in addition to drawing less labs, the labs that we do need, we may be able to sort of consolidate or limit by point of care labs, low fill tubes, checking a blood gas. We utilize this a lot in trauma and ICU because it gives you a lot of information in one point of care test. And then in our critically ill patients that have arterial lines or central venous lines, you can often not waste any blood as you draw their labs. And then as we manage anemia, we want to focus on the treatments part of things. So we do have what we call an anemia protocol at our institution that addresses all of the substrate that your bone marrow needs to make new blood. So we keep in mind that as our patients get behind in their anemia, especially when they're hospitalized or critically ill, it's not going to be easy for them to recover and make new red cells. So we want to help them with all the things they need to try to recover their anemia. Most people who have a massive hemorrhage are going to be iron deficient because they're losing iron as they bleed as well. So we would check their iron studies and keep in mind that you want to focus on likely the total iron and the TSAT, that ferritin is not going to be a useful measure in a patient who's critically ill because it's an acute phase reactant. So we want to make sure we're providing iron, B12, folate, and then erythropoietin, especially in our bloodless patients or in patients who have renal problems, and we know that they don't have normal stores of endogenous erythropoietin. So again, this is kind of a summary of our anemia protocol using IV iron in bloodless patients or patients with severe anemia. We try to also use this in our patients who we know are going to be having more surgery and more blood loss. Often our trauma patients have multi-system trauma and possibly multiple orthopedic injuries, and they have these serial surgeries. So we know that they're going to lose more blood going forward. So we try to get on top of their anemia even earlier and not wait until it's severe to treat it. So a bit about coagulopathy, which is another thing we need to be very suspicious of our patients' blood health and trauma. This vicious triad of mortality in bleeding trauma patients includes coagulopathy, which we'll talk about, hypothermia, so it's important to focus on keeping our patients warm, and acidosis contributes to bleeding as well. So as far as the acidosis, as we mentioned, we want to stay away from normal saline. This will cause a hyperchloremic acidosis. So if you're using crystalloid, we'd focus on LR. We know that this is exacerbated by any trauma or tissue injury. So we want to be keeping an eye on our pH and making sure our patients aren't too acidotic. Similarly, hypothermia is going to cause a functional factor deficiency. So we want to make sure that we're limiting hypothermia by both warming the patient, warming any fluids or products that the patient's getting. This also contributes to platelet dysfunction or worsening coagulopathy. And then we know that coagulopathy of trauma is its own entity. So just by virtue of being injured, you're at risk for coagulopathy and platelet dysfunction. Even in our young, healthy people who don't take any anticoagulants or antiplatelet drugs and don't have a lot of comorbidities, they're at risk for these problems. So we know trauma-induced coagulopathy is seen in up to a third of our injured patients. These patients have higher transfusion requirements and worse outcomes. So we want to be suspicious that all of our patients are at risk for this and identify it and correct it. Similarly, patients with traumatic brain injury are at risk for coagulopathy. And we know that at some point, almost all of our trauma patients are going to have some degree of platelet impairment. So we want to be on the lookout for these things. A lot of things associated with our trauma patients also can lead to coagulopathy, like alcohol use or, as we mentioned, over resuscitation with crystalloid fluid. And then a lot of our patients, as the population ages, are on these medications that need to be addressed. So anticoagulant medications, antiplatelet medication. And Dr. Burns talked quite a bit about liver disease and keeping in mind that that's an unbalanced clotting system, and it's not automatically assumed that those patients are likely to bleed. Similarly, kidney disease, uremia, hematologic disorders, iron deficiency is very common in our population, as is at times poor nutrition. So these things are going to contribute to our trauma patients just like they attribute to, or they are problems in our general population. So we need to be, again, have a heightened awareness of coagulopathy. I think we touched on these things, but DIC can develop, and then again, hemodilution, both from bleeding and unbalanced resuscitation is going to contribute to coagulopathy.
Okay, I'm joining now. Thank you.
So we want to manage coagulopathy by reversing medication effects if the patients are on these drugs, and then defining what the problem is and supporting their coagulation. So again, these are all options that are listed for bloodless patients if they accept these things. And I stayed away from sort of the traditional blood products. So for Coumadin, as we've heard, vitamin K and prothrombin complex concentrate are the gold standard for reversal. In our institution, we use FIBA. I know PCC is also used to reverse some of these DOACs. There are antidotes available. I know andexanet alpha is sort of prohibitively expensive. That's not available at our institution. We do have Prexbind, or the antidote for dabigatran. And then for the antiplatelet medications, as has been discussed somewhat by our other speakers, DDABP is an option to help reverse platelet abnormality. This works by increasing von Willebrand factor and platelet adhesion, and it's been studied and shown to reduce the need for transfusion without a significant risk profile. We studied this at our own institution in our traumatic brain injury patients who all get viscoelastic testing, and we noted, including platelet mapping, we use TAG here, and we noticed that giving DDABP reversed platelet inhibition just as well as giving DDABP plus platelets. So we see that the platelet transfusion is unnecessary, and we typically treat with only DDABP unless the patient is rapidly deteriorating. So viscoelastic testing is important, as I think Dr. Burns really elucidated. Traditional coagulation tests are not going to give you a good picture of your patient's risk of bleeding. So we want to use viscoelastic testing to really define what coagulopathy may exist so that we can focus on what the patient needs to stop bleeding. It's also a quick test. You can get a point of care version or you can get your results relatively quickly, even in trauma when we're looking for lysis. That is measured at 30 minutes. So just after 30 minutes, you'll have your complete results for a TEG. Obviously, ROTEM is another option. And again, this will give you multifaceted information about how your patient's clotting or not clotting so that you can address it very specifically. And this is just sort of a summary, again, focusing on non-blood products for possible treatments of abnormalities in your TEG. So with a prolonged reaction time, you want to address clotting factors. So without using plasma, you could use PCC, vitamin K. If you have a fibrinogen deficit, if your patient accepts cryo, that would be an option. And if you have platelet dysfunction, DDAVP may be useful. And if you do have fibrinolysis, again, we use TXA upfront in all of our massive hemorrhage protocol activations. But if the patient continues to lyse, then they get that second dose or infusion dose of TXA after the loading dose. Again, focusing on platelet function, we want to know in the case of an intracranial bleed or a patient who has severe bleeding, even if they have an overall normal TEG, we do want to know if they have underlying platelet dysfunction so that we can address that with DDAVP. So again, our goals of massive hemorrhage protocol are to act early, to reduce blood loss efficiently, to control hemorrhage, limit further functional damage. So this is specifically sort of the case of intracranial, excuse me, hemorrhage, where you're not going to die from blood loss, but the morbidity and mortality is significantly affected by a worsening head bleed. So you want to arrest that as fast as you can. And this will meet SABM standards, which includes management of coagulopathy, using TXA, and using an MHP that also addresses acidosis, hypocalcemia. If your patient is getting transfused, they'll quickly become calcium deficient, and hypothermia. So as far as the protocol aspect of an MHP, you want to make sure you have all the correct stakeholders involved, which is usually a multidisciplinary team, so that your MHP works very efficiently and is kind of reproducible at a moment's notice every time you get an emergent case like this. So our stakeholders include members of our patient blood management committee and our transfusion committee. And we review all of our massive hemorrhage protocols to make sure that the reaction time is good, that the products that we're getting are correct, that each aspect is being paid attention to. And then when we see any opportunities for improvement, these are the same group of people that you want to have kind of reviewing and deciding what we could do better. It's important that it's efficient, and it's important that it has good leadership. So that this is something, again, that's very reproducible and sort of brainless, so that you do the same thing every time and you know what to do. So we learned from our experience in patient blood management and caring for bloodless patients. We especially always come back to that pillar of patient blood management, which is that it's patient specific. Each patient's going to need something a little bit different, and you want to make sure that you're focusing on how to treat that patient and not do what you always do because you've always done it that way, kind of dogma, as we've been talking about. And again, we want to make sure we're stopping bleeding, tolerating anemia. We know that our patients do well at lower counts than we used to think, and treat their anemia early, avoid worsening their anemia with iatrogenic blood draws. And we want to decrease, by doing all of those things, we're going to decrease complication rates, length of stay, and costs. So it's kind of a win-win situation where you're doing the right thing for the patient and sort of your health system by saving. And we know this is a team effort, so we're going to work as a team. And that is all I have.
Thank you, Dr. Sedum. So I think this will conclude our 3 speakers for the first session this morning. And Rebecca, you want to take it from here?
Sure, absolutely. Much thanks to Dr. Burns, Dr. Bloomberg, and Dr. Sedum for their excellent talks. I greatly appreciate that our experts have been answering some questions in the Q&A as we've been listening to their presentations today. So please do take a look at some of those responses. But I do have some questions for each of the speakers. Hopefully we can fit these in just 7 minutes before the next session. I wonder if we can ask each of the speakers to talk about the evidence-based guidelines or lack of evidence-based guidelines that we wind up seeing with each of these items. And starting with you, Dr. Burns, I think that you talked about how many of patients who wind up receiving plasma transfusions, there's never a post-treatment INR to even see that result. And it makes you wonder whether clinicians would change their practice if they could see that there wasn't a great result with that. So along with that, what about evidence-based use of vitamin K in treatment of that? Are those guidelines strong and are they well known to be utilized? I wonder if you could start with that one.
Yeah, sure. And I'm glad someone teed that question up because, the literature does show that the use of IV vitamin K, even in patients, as we mentioned, even in patients that are not on vitamin K antagonists, with or without bleeding, because that most common cause in the intensive care unit is a vitamin K deficiency. So it certainly is reasonable and, in the literature that can effectively reduce that INR, if that's what you're watching, and also benefit your patient in the event that, let's say, they are going to a procedure that you may feel is of, higher risk. Even in those warfarin-induced bleeds, we see that the standard dose most people will look at in IV vitamin K is that 10 milligrams. But clear literature out there that you could, if you use 2 milligrams, 5 milligrams, and you just use the IV vitamin K, particularly in that patient that is perhaps in that gray zone, that urgent but not emergent patient, and you have a bit of time to get that INR down and stop that bleeding, even that smaller dose given over that 30 minutes can be effective. I think one of the biggest take-homes is, and it really feeds into what Aaron was saying when we're looking at those labs, don't draw the lab in the first place if you don't need it, because then you're going to be forced to think you have to react to it. So if that laboratory is not making a difference in that clinical scenario for your patient, don't draw the blue top. and then you won't feel compelled to react. But yes, IV vitamin K is, I think something that is not, to your second question, is that well known? No. That I still run into clinicians that are still worried about IV vitamin K and anaphylaxis. And that is not the case now with the current preparations. Hasn't been for a long time, but people of my vintage, and then that dogma gets kind of pushed through to younger clinicians. And that was, by the way, not the vitamin, that was the emulsifier. So it's a very different product. And I do think we need to stress that, the use of that.
Fantastic. Thank you. For Dr. Bloomberg, I thought in your talk it was really kind of interesting where you use that analogy that it's almost as if everybody's sitting around eating tuna fish sandwiches for lunch, coming up with these guidelines. That's how much background there is behind them. The comment about ABO incompatible platelets. I've almost seen in some institutions that we're looking towards using any more excuse to use our inventory and stretch what we've got versus use things in an evidence-based way. And so I'm wondering if you can comment on, maybe how we might wind up addressing that unsafe use of products like that, as opposed to trying to figure out how we can keep using what we've got when it's giving us such bad outcomes.
Yeah, this has been an enormous challenge. I run a blood transfusion service, so it's it's very dissonant to me that we have these practices that are that I think practitioners at the bedside, like Dr. Seidem, don't realize that their blood bank is subverting their ability to take good care of their patients. It's certainly unintentional, but my colleagues are wedded to the idea that what's really important is inventory control. And obviously, if they thought they were harming patients, they wouldn't be doing it. But the data that's been provided that ABO doesn't matter for platelet transfusion is scientifically I'm trying to think of a diplomatic term. It's methodologically unsound. They characterize patients by what the first transfusion was. And so if you got one transfusion of ABO identical and then 9 of ABO non-identical, well, by God, you were in the ABO identical group. Now, that's not science, that's science fiction. And so the data I provided, I didn't go into the studies that are really, unfortunately, fatally flawed, and there are a couple of them. I think what the blood bank used to do, what we did is over the space of 30 years, started to introduce this first for hematologic patients, because my wife, Dr. Heal, and myself are hematologists, so we know those diseases best. And those are the patients getting a lot of repetitive transfusions. But Dr. Seidem probably gives some patients multiple platelet transfusions in trauma, not because she wants to, but because that's what is required. So introduce it for 1 or 2 groups so your technical staff can learn to manage the inventory and give some ABO identical to the patients who are most vulnerable. Start small and get bigger. We started with hematologic malignancies, moved on to cardiac surgery, and eventually decided we got to do this for everybody. The data is, it's making everybody bleed. It's causing mortality in multiple different groups, but it took us the better part of 30 years to do that.
Absolutely. Thank you so much. And we've maybe barely got 1 minute before we've got to move on to the next one. But Dr. Seidem, I wonder if you could make a comment about damage control surgery and the approach to doing a little less in order to achieve more, rather than everybody feeling like they've got to fix everything all at once.
Absolutely. It's always a little tricky with the handoff, because the surgery team starts in the emergency room with your massive hemorrhage protocol and you're directing the resuscitation. And then you go to the OR and you kind of have to turn it all over to anesthesia so that you can work. and you're hoping you're on the same page and everybody's, keeping the patient warm, addressing their acidosis, giving them what they need to correct coagulopathy and to keep up as you're working. But we like to take back over in the ICU and kind of have one cook in the kitchen type of situation sometimes. But certainly, no matter your best efforts, the patient's going to be cold and worsened coagulopathy as long as you're in the OR. So you want to get out as soon as you can. So whether it's packing, you throw your sutures in the obvious bleeding, you get the spleen out if that's what's bleeding, but you take care of what you can quickly. And otherwise you pack, you correct coagulopathy, come back another day. And similarly, if there's any bowel injury, you segment off or resect the part with the hole. That's not the time to put them back together or close their abdomen. You use a temporary sterile abdominal dressing and get out and come back another day. So the idea is to live to fight another day.
Wonderful. Thank you so much. Thank you very much to our speakers, Dr. Burns, Dr. Bloomberg, Dr. Sudam. Thank you so much for everyone for joining this SABM joint session here at the conference. Perhaps if there are any other questions, I'll ask our speakers to answer those in the Q&A during the next session. But with this, we'll close this one and move on to the next Art of Bloodless Medicine session. Thank you very much, everybody.
Thank you.
So thank you very much, everyone. That was a fantastic session. And we're now transitioning to the Art of Medicine session. Now, this session traditionally, it has either artists who are interested in healthcare topics or healthcare practitioners who are interested in artistic topics or want to collaborate art with their healthcare practice. And last year was interesting because there was featured a movie director who produced documentaries on bloodless medicine and also the hazards of blood transfusion. So it's a very interesting session. So this year we are featuring a real all-time great surgeon / artist, or artist / surgeon, obviously bringing art to the surgical field and surgery to the art field. And I will hand over his introduction to actually my co-moderator. That's Sandra Mann. She's an RN from United States of America. She's got years of experience in various bloodless related topics. But one thing is that I'd like to just say she's a remote triage nurse from Mercy Clinics in Mercy Health System USA. So Sandra, take it away, please.
Thank you, Dr. Shar. There's so many to thank and there's so many to welcome. It's been such a wonderful BMSS conference with so much rich information and insight. So I just wanted to say a quick thank you for that and for welcoming me as well. One of the things we did want to do right now is very precious to us is Dr. Nadi Hakim, who is going to be presenting, and his presentation is going to be on bloodless renal transplant, music, sculpture, and other forms of art. So actually bringing that into bloodless medicine. So I just wanted to take a moment and introduce Dr. Hakim, although we are running a little short of time, and Professor Nadi Hakim has a string of qualifications that are almost too many to mention. It could fill a whole page, but I did want to mention that he has a medical degree, and among many of his qualifications, he's got a PhD, a fellowship of the Royal College of Surgeons of England, a fellowship of the Royal College of Surgeons of Ireland, fellowship of the International College of Surgeons, and fellowship of the Royal College of Surgeons of Glasgow. And those are just some of his accomplishments. There are many more here. I was very impressed with, he is a prolific author and sought after international speaker with over 250 peer-reviewed papers and 24 textbooks. And that's a huge accomplishment, Professor Hakim. So he has been made the Chevalier of the Légion d'Honneur in 2016, and I'm sure I did not pronounce that correctly, but it is a very prestigious title to have and very well deserved, I'm sure. So now we want to present Dr. and Professor Nadi Hakim with his presentation of bloodless renal transplant, music, sculpture, and other forms of art. Dr. Hakim.
Thank you so much. I hope you can hear me, correct? Excellent. So I will try to catch up with the delays. Don't worry. Being a surgeon, we try to speed up things. So I hope I'll finish on time. Thank you so much for this very generous introduction. My title of the talk is My Journey to Surgery, Thunder and Lightning to Sunshine, because all of us have had ups and downs in our career, and this is what I want to share with you today. And I know I was asked to talk about the bloodlessness of surgery and transplantation. I, as a surgeon, I believe that every single surgery should be completely bloodless, whether it's transplant, thyroid, the field has to be completely free of blood. And this is how I work in all surgeries. It doesn't apply just to transplant. And when I see a surgeon using just scissors and cutting and bleeding from everywhere, I really think this is not the right way to do it. So I will start by just giving you a bit of an introduction about where I come from initially. Although I was British born, but this is where I grew up initially when I was a kid in this city on the Mediterranean Sea. It looks like a very quiet and healthy and nice city. However, when I grew up, this is what has happened, and this is what we can see today in many other parts of the world, whether it's Ukraine or Gaza or the Israel. Cities will burn, and when they burn, people who can afford leaving and have the chance to depart will end up leaving. If you see this kind of features from your balcony, and this is what happened to me as a kid. I ended up going the first stop to Paris. Being British, we were welcomed there. And at that time, I was just finishing schooling, and beautiful Paris welcomed us all. And I entered the medical school in Paris. The school I went to was called the René Descartes University, which is named after the philosopher Descartes, which I'm sure you all heard of. After completing my medical school, I was honored to be awarded the medal of a laureate of the Faculty of Medicine in 1984. And this was the medal I was given, which depicts Hippocrates. And I'm showing next to that a sculpture which I was offered by my father when I was still a kid, and because he knew I always wanted to be a doctor. But you see the resemblance of that sculpture with the medal which I was awarded for my hard work at medical school. Following this, I went to Guy's Hospital in London, which is part of King's College Hospital. And as a matter of fact, my daughter now is 25, is a medical student at King's and Guy's. So it is an incredible coincidence. So I went to medical school in Paris, but then I finished my training in surgery at Guy's. And at that time, even at that time, this picture dates from 1982, there were still strikes in London. And you can see here with some foreign medical students next to me. And I'm showing this picture because it is important to note that on that picture, I have 2 German medical students and 2 American medical students. And the reason I'm mentioning this, because those 4 medical students have shaped my future. And I tell you why, because the first one shown here ended up being in Chicago, and I met him in Chicago. And the other 2, one was from the Mayo Clinic as a medical student, and the other one from Hopkins. So these were the first times I've heard those names of hospitals. And I mention this because this is what happens later, and you'll see that for a fact. Thanks to that guy from Hopkins, I contacted Johns Hopkins as a student at the time. I said, I want to do a fellowship at Hopkins. So I was accepted, and I did a pediatric surgical fellowship at Hopkins. The Mayo Clinic came after, and again, thanks to that American medical student, I contacted the Mayo Clinic and I ended up doing a fellowship in GI surgery at the Mayo Clinic. And this is the gentleman you saw in the picture before. Now, this is the medical student who was at Guy's, but by this time he was already a fellow in orthopedic surgery in Chicago. So I went to visit him when I was at the Mayo Clinic, and we were walking in Chicago along the Lakeshore Drive. And at that time, we talk about 1987 now, there was no mobile phone, no social media, nothing. So we had no idea how to contact anything. And I was passing by this building, and I wanted to see this plaque here, which says International College of Surgeons. I knocked on this door, went in, I said, you know, I'm a future surgeon or surgeon in training. I'd like to be associated with this college. And indeed, I ended up becoming a fellow of the college. But not only a fellow of the college, 20 years later, I became the president of this college. Would you believe it? It is truly an incredible story. Thanks to my stay at Mayo, which is in Minnesota, I ended up going to do a fellowship in transplantation at the University of Minnesota. This is where I trained to do pancreas transplant. And coming back to London, I performed the first ever pancreas transplant in London. And thanks to this, I was asked by Oxford University Press to write a book, or to edit, more precisely, a book on pancreas and islet transplantation. And my co-editors were Rob Strata, an American transplant surgeon, and Derek Gray, who is now gone, from Oxford. This was one of the books I've edited. And then it was so popular that 10 years later, I did a second edition, but this time we added stem cells. And not only this, I added a few more editors. The last one here, Alan Coleman, is the guy who's done the first ever Dolly the sheep. And I got him as a co-editor to tell you how significant that book has become. And it was forwarded by Gabby Danovich, who is a nephrologist from UCLA. We spend our time doing bloodless surgery in theaters, and this is what I was doing here, kidney transplant at St. Mary's. St. Mary's that's where Alexander Fleming worked, and this is actually exactly where penicillin was discovered. Along this first floor was the offices of Alexander Fleming. He discovered the penicillinum at that time on that window, having left a Petri dish on the balcony. So this is, again, historic because that's where my office was, on the second floor of that building. A book on transplantation, edited by myself for Imperial College, again, was a very satisfactory book. I entitled it Introduction to Organ Transplantation. And funny enough, you know, I come from a musical family. My brother is an organist in Paris. And coincidentally, he's written a book called Introduction to Organ Improvisation. So it is incredible that I ended up having an almost similar title of my book. And this is a second edition of the same book, because when a book is popular and sells, the publishers want to have a second edition. It's quite a good sign. As is another book on dialysis, and this again from Imperial College. My co-editor here is Jacob Ako, who is from Nigeria. And I've asked Roy Khan to do the painting. And at that time, Sir Roy, who was a friend of mine, offered to do a painting of depicting the AV fistula. back to theaters again for Bloodless Surgery, and another book, Transplantation Surgery, this time with Gabi Danovich, a gentleman from UCLA. This book was very interesting because it was published by Springer Verlag, and the introduction was written by a Nobel Prize winner called Jean Dosset. Now, Jean Dosset is the gentleman who got a Nobel Prize for discovering HLA, which we use now on a daily basis, but he was the Nobel Prize, French Nobel Prize, who got the HLA discovered. And this is a second edition from actually last year with a few more editors. One is Mehmet Haberal from Turkey and Daniel Malouf from the US. And this is the part of the introduction forward by Jean Dosset, the Nobel Prize, who's written it actually initially in French, translated, and this is still in the second edition of the book. So this is truly an achievement. I was very proud to have a Nobel Prize winner writing a forward for my book. Another textbook on pancreas transplantation, this time with yet another French co-editor, Michel Dubernard. And I mention him because he is the gentleman who eventually led the first arm transplant performed in the world, and I was part of that group. This is Jean-Michel Dubernard, who sadly died last year of a heart attack while he was in Turkey at the airport, but very sad. But he has made history by facilitating the first ever arm transplant. This is me doing a pancreas transplant, and this is what I've started at St. Mary's many years ago in 1995. All these patients have had a kidney transplant. All were cured of their diabetes. It is an incredible sensation to have all those people, and now many more people in the world have had their pancreas transplant. And I mentioned Jean-Michel Dubernard. Indeed, he is the gentleman I worked with to do the first ever hand transplant, and I was part of the team representing Britain at that time in 1998. And this is some pictures of the first ever arm transplant in the world. This is a cadaveric donor where you see here in 1998, the first ever arm transplant in the world. And this is the gentleman who had it done, Clint Hellam, who was from New Zealand. And you can see here, I was visiting him at the hospital in Paris, in Lyon, where it was done. And he came to visit me in London with his functioning arm. Having said that, 2.5 years later, I had to amputate the arm in London because he stopped taking his medications, because transplantation without immunosuppression is a failure by definition. And many years later, this is 2021, he died, but having been the pioneer in arm transplantation in the world. You have to admit and agree that this is a big, big thing to do, to accept to be the first ever guinea pig, I would say, to have an arm transplant. This is the second patient we've done. This time it's a double arm transplant, 2 arm transplants performed. And this time it is a Frenchman who had it done. And this gentleman still has his arms after 25 years. So it is quite an impressive achievement to have this gentleman. And we end up going actually to Rome together to visit John Paul II, because he was a fervent Catholic and wanted to visit the Pope. And this is me and him and Jean-Michel Dubernard when he came to visit us in London. We ended up writing a book on composite tissue allograft, which is the same as arm transplantation, and my co-editors were Jean-Michel Dubernard and Earl Owen, who is the pioneer in microscopic surgery. As the introduction mentioned, I have a hobby. I do sculpting, and this is when I was doing the sculpture. I hope you recognize it already, the sculpture of Her Majesty the Queen. 20 years ago now. And it ended up, at that time, she was younger, obviously. And this is a sculpture which is at Buckingham Palace. I offered it to Her Majesty at that time. And many years later, just before she died, I ended up doing another sculpture of Her Majesty. But this is 2008, where I got a letter from Buckingham Palace thanking me and saying that the bust will be part of the Royal Collection Trust at Buckingham Palace. And this is more recently, just 2-3 months before she died. And as you can see, an older lady, still very elegant, but this is now at the Commonwealth headquarters in London, exhibited permanently. I'm just showing you a short video of how it looks like so that you have an idea. This is a bronze sculpture of Her Majesty. I mentioned to you the visit to Lakeshore Drive in Chicago, and eventually, as I mentioned, I became 2004 the president of the college. And these are my predecessors. You can see the difference in age. I was hardly 44 at that time, but my predecessors were all in their 70s, having been president. So I was very proud to represent the UK as a president of the college. So this is my medal, of which I was very proud. And this is the same site where I took the first picture at in front of the college, with the British flag and the US flag being flown at the college. And I was representing the college at the WHO, and back to theaters again to do bloodless surgery and more books. This is a book called Surgical Complications, where I chose to put a painting which depicts the doctor repulsing death. You can see that lady dying because she's being pulled down by the skeleton, but the doctor repulsing the skeleton to salvage the life of this patient. Now, a patient of mine, an American patient of mine, said, you know, this painting depicts someone else, so I'm going to order another painting with your face on. And this is what he offered me with the same picture. More books again in hemostasis. This is obviously a book about bloodless surgery, because that's what we are here for. And you end up operating with no blood required in theaters. And when I do my transplant, to be honest, I can't remember the last time I required to give blood to the patient. This is the Hammersmith Hospital, where the transplant unit is. This is where 200 plus transplants are performed on a yearly basis. A sculpture of mine is at the entrance of the hospital. I fashioned this sculpture, but in exchange for £3 million donated by the gentleman. So I told him, can you give us some money for research? He said, yes. I said, I will do your sculpture and it will be exhibited in front of the entrance of the hospital. And we named the unit after him. It's called the Navmi Ouchi unit. He's now Sir Navmi Ouchi in London. And this is the £3 million, just thanks to a question I've asked and a sculpture I've done. The Royal Society of Medicine, I was the vice president until probably 4 or 5 years ago now or more. And this is a place I'm very proud of. I did another copy of the same sculpture of Mr. Ouchi and got £750,000 for the second sculpture for the Royal Society of Medicine. And this is the Chicago College of Surgeons, where I was president. As you can see, these are member of council at the college. And again, another copy of the same sculpture, $500,000. So this gentleman has been very, very generous and has donated almost £5 million for medical activities, just thanks to a sculpture like this one. And this is the chief executive of the college, Mr. Max Dowden. And eventually, you know, people ask me, can we do a painting of yourself doing surgery? And this is myself with the college members performing a nephrectomy. And this painting was at the National Portrait Gallery, and it won that prize in 2010. And even the BMJ chose it as the picture of the week on that year, 2010. So again, I managed to highlight that picture not only in the museum, but again in the newspapers, where an article in The Guardian says surgeon inspired by Rembrandt in that particular picture. A book on bariatric surgery, which I do, which got the BMA highly commended book in 2012. And talking about sculptures, this is David Cameron, which again I have offered to the Conservative Party. They auctioned it at the dinner and they got £90,000, 90, and it is currently exhibited permanently at the Carlton Club. Should you want to visit the club, you will see it there. And I'm very proud that one of my sculptures has benefited in that way the Conservative Party. Now, as I said, sunshines are not always there, and this is why all of us will get eventually to have a problem. And indeed, almost 10 years ago now, they claimed that I delayed an NHS operation to treat a private patient, which is certainly not the case, but you know, some jealousy will happen. And this is why even in the papers, front page of the Evening Standard, World Transplant Expert axed by the trust for gross misconduct. So I sued them, and the judge thought I was right, and I was reinstated after a year and a half. Of course, it took time, but again, I got my revenge because I had done nothing wrong on that day. While I was off the hospital, but still doing private work, that allowed me to do more sculpting. So I went to Florence, and I always wanted to do the head of David Michelangelo. And this is what I've done while I was in Florence. And that sculpture is now at the museum in Tuscany, in the Museum of Pietro della Francesca, as you can see here. It is in the gardens of the museum, and this will be there forever and ever. This is a team from the UK who visited the museum with me and saw that sculpture. The French, and I owe the French a lot, honored me by giving me La Légion d'honneur. And this is the highest order you can get. And I am very proud of this honor. It is equivalent to the knighthood from the UK, although I'm not a French citizen, but I was honored by the French and given that Légion d'honneur, which I am very proud of. And this is, at that time, Jeremy Hunt, who was health secretary, who came to the ceremony at the French embassy with the French ambassador, who awarded me the Légion d'honneur medal. And because of that, eventually I ended up doing the sculpture of Macron. And this is a very nice message he sent me, pour Nadia Hakim, en hommage cordial, cordial homage by Emmanuel Macron. And this is the same copy, which is now permanently exhibited at the French Embassy in London, in addition to the Élysée Palace. Sculpting again, the Pope, John Paul, Pope Francis. Recently, again, I offered him his sculpture. And you can see from his eyes, he was very pleased with it. And this was in 2018 in the Vatican. And he was blessing that sculpture, which is now at the Museum of the Vatican. And this is how he looked like almost 10 years ago now, or less. Obviously, he got older recently. And I didn't stop that. I ended up going even to North Korea. People say, why North Korea? He's a monster. Yes, of course. But this is not why I did it. I did it, it's art. It's art. And thanks to that sculpture, I ended up visiting North Korea, invited by the government of North Korea to give lectures on medicine and transplantation. And this is what was highlighted in the papers in London. And not only North Korea liked it, but South Korea was jealous. So they contacted me. They say, oh, you've done North Korea, so you should do Moon, the South Korean president. And this is why I think you should open to all venues and not be restricted to only one. This sculpture of Boris, which is at the Downing Street, which I offered to him. And I want to share with you, hopefully it will work. This is when I offered it to him. So he had no idea he was going to be offered that sculpture. So, and we have now to please the Americans too, although not all of them like Donald Trump. But again, I've done his sculpture, and I tell you, knowing Trump, he loved it. He loved it so much that he sent me this message, so great, and he signed it. So this was last year, actually, no, two years ago. And then we'll see what happens in the next elections. So you mentioned the music and the art. Music, I play the clarinet almost on a daily basis, and I enjoy it. It relaxes me. And I would like to share with you here, if you don't mind, because I was asked to. So I will not bore you more than this with this, but this is to give you an idea about what music is all about. And this is the sculpture of the first ever doctor in the UK who died of COVID-19. He was my registrar. And after his death, because I liked him so much, I fashioned his sculpture and offered it to his kids, well, doctors, to his wife. So this is reminding me, at that time he was 64. And I really liked him so much. He came originally from Sudan, but he died, sadly, of COVID. And someone asked me to remind us what COVID has done. And I thought of the sculpture of a skull with the virus on top of it. It summarizes what the virus has done. The virus has killed so many, and we end up skeletons because of that, sadly, the virus. And this was used as a picture in one of the Portuguese journals of surgery by the editor. Now, I would like to share with you the sculpture of well, unfortunately, it doesn't seem to show. but that was a sculpture of President Modi or Prime Minister Modi, but it did not show. Here is with the king at the dinner, because at that time I was the vice president of the British Red Cross and he's the patron, so he invited us to dinner at Clarence House. And this is the sad what happens, unfortunately, in Lebanon. And this is music I've played with some pictures to show you what happened to Lebanon. As you remember, there was a bomb which happened, which blew up. And see, this is what the destruction before and after. Complete destruction. Watch the bomb now. See, very sad. So the hospital where I work now is the Cleveland Clinic, London, which is a satellite hospital of the Cleveland Clinic in Ohio. And I'm very, very proud of that. I'm a professor of surgery there. And ladies and gentlemen, Mr. Chairman, I want to complete my talk by mentioning Charles Mayo, who said, if we excel in anything, it's in our capacity for translating idealism into action. And lives of great men all remind us we can make our lives sublime and departing, leave behind us footprints on the sands of time. Death comes to us all, but great achievements build a monument which shall endure until the sun grows cold. And I finished with Khalil Gibran's statement, if I accept the sunshine and warmth, then I must also accept the thunder and lightning. Thank you.
Thank you so much, Professor Hakim. That was a most wonderful journey into your life, your career, and all the good that you've done for not just patients, but for the entire community, or communities, I'd like to add, and how not just healthcare, but music and sculptures can bring people, even though we may not agree with one another, we at least can respect one another and learn to get along with one another. And a really sober reminder that there's much work to be done, because we do not live in a world that is at peace right now. And our hearts and prayers go to all those innocent ones who are suffering. And I know we remember fondly what's happening in your home country as well. So thank you for bringing that, and thank you for reminding us. So thank you very much. We're very honored to have you and to close out the proceedings in such a wonderful fashion. So thank you very much, sir.
Thank you, Dr. Char. Very kind of you. Thank you so much. Thank you.
It's our pleasure. Sandra, I don't know if you wanted to add anything, or if you wanted to open the floor for questions. You might just want to unmute yourself. I think you're just still on mute.
Thank you, Dr. Shar. Yes. So I'm opening up the questions right now, and it looks like, let me see if we can come down to there was so many earlier. Would like to say that we have from Garba, Professor Hakim, your ability to blend art with surgery is truly remarkable and highly informative. Your expertise and creativity left a lasting impression, and I appreciate the valuable insights you shared. I believe that attendee speaks for all of us, as we can see that you've left a lifelong legacy, Dr. Hakim, with all of your art and medical pursuits. There's also, let's see here, really, that looks like the only comment, really. There's many thanks by a lot of attendees, and we are so thankful for that too. Did we want to open it up to the panelists at this time if they would like to contribute or share?
I think we have Nathaniel with his hand up, Sandy.
Okay.
I think Nathaniel, you're still on mute.
I'm so sorry. Thank you very, very much, Professor Hakim, for coming on this platform. As you can see, everybody's dumbfounded, including myself, who actually had a bit of an insight into what you were going to say. I want to let everybody know that Professor Hakim is an extremely unusual person, very remarkable. Many years ago, when I was involved in organizing a local conference of the International College of Surgeons, Professor Hakim was just finishing his tenure as the world president of the International College of Surgeons. And I invited him to Nigeria, to Calabar. And the International College of Surgeons wrote to me that he wouldn't be able to make it. The British also wrote to me. I mean, I didn't know he was such a diplomatic personality. So they wrote to me and said, sorry, he cannot be there. But Professor Hakim got through to me and said, don't worry, Nathaniel, I'll be there. And surely he came. And it was an amazing experience. This tie I am wearing, he gave it to me when he came to Nigeria. And he didn't stop at that. He also gave me this book on hemostasis in surgery and the book on surgical complications. You see, a short while ago, I asked a friend of mine if I could have a book that he wrote, he published. And he said to me, you can get it from Amazon. And I remembered Professor Hakim and how he brought these heavy books all the way from UK. And not only for me, he gave it out to other fellows of the International College of Surgeons. And sometime later, I had opportunity to visit his practice, his Harley Street practice, and he gave me another book on bariatric surgery and gave me a ride in his electric car. Those days, it was difficult to even find one electric car, but he had one. So for him to come on this platform here, I mean, it's really a humbling experience, and I want to thank him very, very much for coming on here.
Actually, Nat, Dr. Soro, I'd like just to add one thing, if I may. The talk is about bloodlessness in surgery. I believe that whatever we do should be bloodless, not only surgery. And I think not wasting your time in life is, again, another bloodless procedure, because you should not waste your time. It's too short, valuable, and irreplaceable.
Thank you for that pearl of wisdom. Thank you.
Thank you.
Thank you for your wonderful participation for this session, everyone. I really enjoyed, obviously, the presentation from Professor Hakim. Thank you, Sandy, for co-chairing the session. And also, we've got a couple more comments. Just a quick one from Dr. Garba. Professor Hakim, your ability to blend art with surgery is truly remarkable and highly informative. Your expertise and creativity left a lasting impression, and I appreciate the value insights you shared. Omar has invited you to build a hospital in Lebanon, which I'm sure must be at the top of your mind. And I know there's still a huge amount I can feel that's going to come from you, Professor Hakim, whether it's in Lebanon or sharing expertise around the world. So thank you very much, everybody, and thank you very much, Professor.
Thank you, Amit. Thank you, Sandy, and thank you, Nat, for your very kind words.
Fantastic. Thank you, sir. So we'd like to transition now to the annual general meeting. I'm going to invite our BMSS president, Dr. Nathaniel Usaro, if I got that. I hope I pronounced that right, Nate, to take over. Thank you very much for the honor of allowing us to chair this.
Thank you, Amit. The honor is ours to have you. We know how precious your time is, and you spared it, and Sandy also. And of course, that goes for all the other speakers, right from Wednesday till today. They are all people whose time is extremely precious. But the fact that they spent their time to honor us, honor our invitation to come and share the wealth of their knowledge with us is something we really need to be thankful for. I don't want to do the vote of thanks. Sandy will do that later. So I would like to share a slide to start us off. And I would want to say that right now, all of us we should remain here because we want everybody to be part of this. Just a second. Okay, so I'm trying to share my screen. Right. Okay, so we are in the annual general meeting now, and we are 168 participants in this meeting. So please, let's remain that way till the end. The agenda is the welcome, and then the review of BMSS 2022, updates on BMSS 2023 award, and BMSS 2024, and then any other business, AOB. So within 30 minutes, we'll be through with this. So let me welcome all 167 of us to the annual general meeting. And it doesn't matter if you're not yet a member of BMSS, but if you're interested, please send us a mail, info@bmsssociety.org, and we'll send you the forms. You can fill them out. So this was our meeting last year, the 2022 annual general meeting of the Bloodless Medicine and Surgery Society. The theme was Bloodless Medicine Education, the ultimate game changer. We've been talking about how do we change attitudes, beliefs, and so on. And we believe that education is very important to this. So the conference the conference chairman for this 2022 conference is here, and he's going to share with us a very brief report about that conference. So I'm now inviting Dr. Christopher Simutoe, or should I say Mr. Christopher Simutoe, being a fellow of the Royal College of Surgeons of Ireland as well as of Edinburgh. So Chris, over to you.
Thank you very much, Nathaniel. Last year, the BMSS annual conference and scientific meeting, the theme was Bloodless Medicine Education, the ultimate game changer. For those who registered for the meeting were 1,103, and they were from many, many countries in Africa, Europe, America, South America. It was well attended. I'll just briefly go through the program that was presented. All these are on YouTube, so we can, I'm just trying to entice you to still go back and review them on YouTube. Okay. The keynote address from Dr. Ariel Shanda was the Bloodless Medicine Education, the ultimate game changer. Surely, he really brought up the importance of language. And then sometimes we misuse language and it can bring in prejudice. And there is need for us as clinicians to actually know how to convey messages to our patients as well as clinicians. And that patients have a choice. We should follow the patient's choice, not focusing more on their religion. The next presentation done by Michael Obeck on the treatment of iron deficiency anemia, this was very good. The take home for me was the treatment of iron deficient anemia in pregnancy. And I think after this, all my antenatal mothers in the second trimester and third trimester, I'm treating them iron sucrose with very, very good results. The third one was improving outcomes through bloodless medicine surgery in obstetric care by Dr. Jonathan Waters. It was very, very excellent as well. On Thursday, we had bloodless medicine education with experience from Malaysia, where Dr. Jamila presented very nicely the experience in Malaysia. We really saw how advanced they are and how well organized they are in Malaysia. It was very great, actually, to listen to that. Then we had also experience from Spain. Professor Sola Erbil presented also quite a very, very remarkable presentation. And our own Cher Ozawa presented NACE as a bloodless medicine educator experience from USA. It was very good. And I was happy this time I saw something like PB nursing, which might come as a career in PBM, which is a very, very good way forward. Friday, our SADBAM colleagues, the first day, there was still some other presentations on perioperative anemia prevention, diagnosis and treatment of blood transfusion by Professor Vernon Law. And it was an excellent presentation. The next was bloodless care in critical care medicine. Education is key for the anesthesia by Dr. Stephen Frank. Also excellent for the anesthetists. And the last was the bloodless surgery techniques in trauma with superior outcome. Erin Soden presented that. On Friday, our SADBAM colleagues presented excellent presentations. Why does blood transfusion result in tissue hypoxia? Dr. Majid. And the spectrum of immunomodulation, a case for transfusion avoidance by Dr. Neil Bloomberg. It was excellent. Really what came out so much was the PBM, State of the Science or State of Art by Dr. Karen Burns. I think she summarized the whole week's presentation so beautifully, so that it was very, very encouraging to actually see this and to bring up the good definition of PBM. Okay. What came out for me as a challenge was something she posted, saying, weaning doctors off their love affair with the blood is going to be harder than we think. I think this is a challenge for us. We need to see how we can actually do this. This also goes back to the mission of the Bloodless Society, which says to bring home the benefits of current scientific evidence in blood transfusion avoidance to patients and clinicians all over the world by encouraging the teaching and practice of BMSS. Okay. Lastly, what this wonderful video, The Making of First Do No Harm, a documentary by James Reynolds. It was an excellent history of blood. I think that was just a very brief presentation of BMS 2022. And please, these things still on YouTube, we can still go back. Thank you, Mr. Chairman.
Thank you so much. Thank you, Chris. That was an excellent recap. So let me see about going back to where I was on the PowerPoint. I think this is right. So that's where we were. And we just had a summary of how that conference was. It was really fantastic. So the second item, the third item on the agenda is updates on the Bloodless Medicine and Surgery Society. The society is an international multidisciplinary society of experts and stakeholders in blood transfusion avoidance, which was founded in 2015. And Dr. Simutoe has told us a bit about our mission and our vision. Our mission is to bring home the benefits of current scientific evidence in blood transfusion avoidance to patients and clinicians all over the world by encouraging the teaching and practice of bloodless medicine and surgery, as well as research and dissemination of scientific information on BMS. Now, that's bloodless medicine and surgery. So, for instance, Dr. Simutoe has reminded us what we heard from Dr. Refai, who was one of the moderators today. And he clearly showed with his team of researchers that transfusion actually causes tissue hypoxia and sustained hypoxia at that. And yet, we as clinicians, we tell patients that we want to improve your tissue oxygenation. That's why we're transfusing. Lo and behold, we're actually doing the opposite. And this is just a tip of iceberg. So many other things, the issues of immunomodulation and so on. But this knowledge is not really disseminated. We still have doctors telling patients, this is going to improve your tissue oxygenation, or this is going to make your wound heal faster, or you go home sooner. Whereas all of that is the opposite that is true. So this is a platform, this is a society where we try to share the correct and scientific information regarding bloodless care as a superior form of care. It's not just an advocacy. And our vision is to establish bloodless care as a global standard of care for ethical and evidence-based practice of medicine, rather than as an alternative. So we may say it looks like we are the only society in the world that advocates bloodless as the number one, but not really. There are other societies who have such visions as well. For instance, the SABM was recently involved in producing a new definition, a modern definition of patient blood management, which basically involves making use of the patient's own blood and aiming to get a better clinical outcome and protecting the patient's rights, which is what we define bloodless care as. And it's not surprising that we reached out to SABM and we became an organizational affiliate of the SABM 2 years ago, 2021. So the update on that is that we have yet another society that has joined us. And so we have the Malaysian Society of Patient Blood Management. Just last month, we became organizational affiliates of each other. And incidentally, the Malaysian Society of Patient Blood Management is also an affiliate of SABM. So you find members of SABM being members of BMSS, members of BMSS being in SABM, and Malaysian Society members in SABM, and so on. So in BMSS, members of SABM and members of MyPBM have actually complementary membership of BMSS for 1 year. And as you noticed, we also have actually a session, a full session for SABM, and we'll definitely set that up also for the Malaysian Society of Patient Blood Management. Although already they have been involved in our meetings. They've been giving talks in our meetings and presentations. And Dr. Jamila Tata is actually our conference chairman for this meeting. And she is the president of the Malaysian Society of Patient Blood Management. And we have other members of that society who served as moderators and so on. So now, the other updates is that earlier in the year, we sent out an email to all members to nominate the president-elect for Bloodless Medicine and Surgery Society. Because even though I am an African, but I don't want to be a life president. And so the nomination came in, and the Board of Trustees took a look, and somebody stood out in that nomination. And that is Mr. Christopher Simutoe. I'm calling him Mr. because that's how the fellows of the Royal College are referred to. But he's actually a medical doctor with a BSc, as well as his medical degree. And as you mentioned, he's a fellow of the Royal College of Surgeons of Ireland, as well as of Edinburgh. And I'm not going to read his citation now because he was one of our speakers. He was one of our speakers for this conference, and his citation was read. But suffice it to say that he's a consultant general surgeon for Luanshya Mine Hospital in Luanshya, Zambia. And it's interesting because Zambia is actually you can say, the birthplace of the Bloodless Medicine and Surgery Society, because it's when I visited Zambia that we put our heads together and decided to start this society. And Dr. Sibutowe has been providing Bloodless Medicine and Surgery services since 1989. He's a full member of the Bloodless Medicine and Surgery Society. And as you just heard, he was the conference chairman for the society last year. Dr. Simutoe is passionate about continuous learning, medical advancement, and bloodless care. And his passion is evident in both his practice and the talk that he gave yesterday on bloodless surgery in the low resource setting. So this is our president-elect, and within the next 12 months, he will be taking over the reins from me as the president of the Bloodless Medicine and Surgery Society. And I'm going to end this. I'm going to stop the share and give Dr. Simutoe an opportunity to say something.
Thank you very much, Nathaniel. I would like to thank the Board of Trustees and Dr. Osoro for showing me the trust to be president of the Bloodless Medicine and Surgery Society. I promise to work according to the guidelines of the Constitution and its mission. I will continue working with the support from the outgoing president, and I hope the support from SABAM will continue, as well as the support from MyPBM, the Malaysian Society for Bloodless Management. One other exciting thing I would like to add on, something I shared with Dr. Soro yesterday, is looking at our mission. We hope in the next 2 years we can propose something like having a bloodless medicine and surgery camp, where we can get all the experts come to one country for a week to provide that treatment. That way we can actually be able to teach others how superior this form of treatment is. Like currently in our country, we do get the cardiothoracic surgeons who come from Japan and the United States of America to stay for a few days carrying out surgery. We also do get ENT specialists from the States or India to do that. Why can't we do that also for the bloodless medicine and surgery camp? It's something that I'll discuss. I'll continue discussing with Nathaniel to see how possible this can work. Okay. I think I'll stop here just for a brief introduction. Thank you, Nathaniel.
Thank you so much, Chris. I really appreciate that. Right. So the next item on our agenda is a highlight of this meeting. That is the BMSS 2023 award. Let's take a look and see what this is all about. Right. So the BMSS Award of Excellence 2023. So this award was instituted in 2015 at the beginning of the society. And it is for an individual or an organization with a track record of outstanding contributions to the science and practice of bloodless medicine and surgery. The awardee must have a track record of outstanding contributions to the science and practice of BMS in any or all of the following areas. It could be academic, clinical, advocacy, or all of the above. And for this year's award, the Board of Trustees of the Bloodless Medicine and Surgery Society unanimously voted in favor of Dr. Jonathan Waters. Dr. Waters was the one that gave the 5th BMSS Arya Shanda a lecture on Wednesday. And just a quick reminder, he's a modest man, so he didn't give a long bio for himself. He's a professor in the Department of Anesthesiology and Bioengineering at the University of Pittsburgh. He's also the chief of the Division of Anesthesiology at Magee Women's Hospital of the University of Pittsburgh Medical Center. He's a member of the McGowan Institute for Regenerative Medicine and medical director of PBM program at TPMC. He's the medical director of the Blood Management Division for Proseca Incorporated, the UPMC-owned biomedical engineering company. His areas of expertise primarily focus on transfusion management, blood salvage, and obstetrics. And he has been involved in federally funded studies with over 150 peer-reviewed publications, 5 books on the topic of blood management, and a book on neurologic disease in pregnancy. Dr. Waters has served on the editorial board of the journal Transfusion and is currently serving as the associate editor of that journal. He is a past president of the Society for the Advancement of Patient Blood Management, and he has served on the board of directors of AABB between 2011 and 2015. He chaired the Blood Management Technical Advisory Panel for the Joint Commission from 2007 to 2016. And so, ladies and gentlemen, I present to you Jonathan Waters as the awardee for 2023 of the Bloodless Medicine and Surgery Society Award of Excellence for his excellent contributions to the science and practice of bloodless medicine and surgery. I think Dr. Waters, I don't know whether he was able to make it. He was intending to be here in order to say a few words. But I know that he is usually very busy in the OR. I don't think I see him here. But I'll show you that it's not just, our awards are not just electronic awards, they are real. This is his award, if you can see it. I'm sorry if the, yeah. Okay, so that is it. And we'll definitely send it to him in the US. Dr. Waters always responds when we request him, even if it's very short notice, we're requesting him to join us for a meeting, he will be there. except when it is absolutely possible. So we're very happy to give him this award. Let me see. I think that okay. I see Dr. Kaufman. Okay, yeah, Dr. Refai is here, and Dr. Kaufman. Can any of you please respond on behalf of Dr. Waters? I think you're his nearest neighbors. I have to cross the Atlantic to see him. And Dr. Sue is here too. So any of you could say something on behalf of Dr. Waters?
This is Lewis. It would be very presumptuous for me to say anything on behalf of Dr. Waters, but I'm sure he is occupied with helping patients and doing worthy things right now. It's mid-morning right now in Pittsburgh. Thank you.
Right. Thank you very much, Dr. Sue. So that is, we'll take that as an acceptance speech on behalf of Dr. Waters. So on that note, we move on to the next item on our agenda, which is basically the last before the any other business. That is BMS's 2024. As Professor Hakim said, not only we shouldn't waste blood, we shouldn't waste time as well. So we should be getting ready already for 2024. So let me see. Right, so let me share this and let us start from the beginning. Right, this is where we are now at 2023 annual meeting, which had the theme Compassion at the Heart of Bloodless Medicine. A very wonderful meeting, in my opinion, and I think many of us have openly said so. The caliber of the speakers, the message, reminding us the importance of showing compassion to our patients. Whether we're, it's actually a quality that all doctors should have, but it's particularly striking in bloodless medicine because the world is yet to accept that bloodless medicine is for all patients, that we don't really benefit our patients when we transfuse them, but we harm them a lot. So for now, a lot of the beneficiaries of bloodless medicine are patients who decline and often met with prejudice. So I think we've heard a lot on that. And next year, the conference chairman will give us a summary. If we, at this point, let me just go ahead of Sandra Mann to just specially thank these members of the BMSS 2023 organizing committee, starting from the conference chairman, who unfortunately is not present right now because she has to, she has a society dinner that she had to attend. It is night now in Malaysia, where Dr. Sata is. The conference secretary, Sandy Mann, she's here with us, and we'll hear from her. Abigail Ivara, who was the first secretary of the society, Blessing who is like assistant administrative officer for us, Dr. Carly Burns, who is SABM president, our brand new president-elect, Christopher Sintoe, and somebody who is about to be past president. And then UD Udrak, who has been simply wonderful as administrative officer of the society, producing virtually all the things you see, like posters, flyers, doing the mails, and so on. So there are others who have been wishing us well and giving us some support in the background. But the ones you see were there in every single organizing committee meeting. And so I say very special thanks to them. But then we are going into 2024. So what is going to be the theme for the 2024 meeting? Again, the Board of Trustees met on this. Letters were sent out to members to send in suggestions for the conference theme for next year. And would you like to see the one that came out tops? There it is. Medical informatics, advancing bloodless medicine. So that will be our 10th BMSS annual meeting, November 6 to 8, 2024. While we are still planning physical meetings in the future, for now, wherever we are in the world, we can join in and participate. And very well. Eventually, we may have physical meetings, and it will also come with its own advantages. So please save the dates and clear your calendar, because we want you to come back. We want to hear from you, and get ready to share with us the names of prospective speakers and topics that would serve us a nice diet of clinical information that we can use to save our patients' lives. So now we are on to any other business. So if anybody has some other business they want to talk about, unmute you. We will make it possible for you to speak. Though I'm suspecting that I may have to. Okay, I think it's possible. Yeah. Oh, a good friend of mine from Malaysia, his hand is up. I think his hand has been up from the first day, but I didn't know how to go about it. Let me see whether I can. Oh, my friends who are running the IT, they might be able to. Dr. Powell, I think okay, you are to unmute. You want to say something? You need to unmute yourself. Okay, while Dr. Powell is trying to figure that out, Dr. Gary, your hand is up. You want to say something? You can unmute yourself. Oh, okay, Dr. Powell.
Hello.
Yes, we can hear you.
Yeah, it's a nice meeting lah. I attend the meeting lah, quite interesting. Thank you for the organizing lah.
Thank you, Dr. Powell. I actually picked up some skills. I picked up some skills from you when I came to Malaysia for your meeting. Thank you. Sorry, Dr. Powell, are you still talking? Okay, I think you had finished. So, Dr. Gary, do you want to say something? Okay, so if any members of the panel want to say something, you can unmute yourself or raise your hand. If there's any other business, something you want us to some burning issues you want us to take care of. But if there is no other business, then I think before Yeah. So in that case, we need to close the meeting. That is the AGM, after which we'll give opportunity to Sandra Mann, to speak to us, give us a vote of thanks. And I think she has a message also from the conference chairman who could not be here in person. So is there anyone who could move for adjournment, please? Okay. So Abigail, please, you can unmute yourself.
So where I am is maybe noisy, but I want to move a bit of time. I actually am so happy with the team of this conference and having all the discussions done here from 2023 or 2022 conference at this year. And nothing else to discuss. I hereby. Thank you very much.
Thank you, Abigail. Is anybody else supporting the motion for adjournment? Because okay, there's a Beauty Monday. She among the is Beauty among the panelists, or is she an attendee? If she's an attendee, okay. So we'll see about allowing her to talk. I'm sorry, Roland, Arjun, you probably could do this better than me.
What do you want us to do?
There was someone called Beauty who lifted up the hand, but maybe she's no longer, or it was an error. So Michael, I think Michael's hand is up. Let's see if we can hear from Michael. Michael, please unmute. You want to support the motion? Michael, you guess it?
Yes, of course.
So we cannot hear from. Okay, is that Michael?
This Maxwell.
Okay, Maxwell.
Yes, sir. I'm supporting the motion.
Surname? What's
Maxwell
your
Adetula.
surname, please?
Maxwell Adetula.
Oh, I see. Okay, thank you so much. We appreciate that. So
alongside with Mr. Obisanya.
Okay, oh great. Okay, Max, thank you. So Maxwell has saved us from staying here till tomorrow. And I thank everybody who was here in this meeting. A lot of us remained part of the meeting from the beginning to the end. And at this time, I will stop my share and invite Sandy over to give us a vote of thanks.
Thank you, Dr. Asaro. So really the list is so many, and including all the participants that attended. And maybe next year, Dr. Asaro, we will have some attendees from Antarctica, as I know that is one of your goals. But really what we want to do is thank from the top down, Dr. Asaro, thank you so much for all the hard work you have put into making BMSS what it has become. And Dr. Burns as well with SABM. This is such a combined effort to make these meetings and also these organizations be the support that they can be to the rest of all of us in medicine. So that I definitely wanted to say. Also, I thought it was very wonderful conference and just really brought in the compassion at the heart of bloodless medicine. We really did nail that, I thought, in a few different facets of our lectures. Just also want to thank the speakers. We had so many good ones. And again, starting with on Wednesday with Dr. Arya Shander, who is just a lifelong loved speaker who has brought so much to the PBM and Bloodless Medicine Forum, as well as Jonathan Waters, who, congratulations, Dr. Waters. That is such a great achievement and an award well deserved. Then, of course, we have Sherry Ozawa, who was able to come and speak despite being, I believe, in Caledonia. And Ilya Husni. Then on Thursday, we had Roland Ndomo-Egba, professor of surgery, start the keynote address. And then we had Marjit Kaufman, who also medical director for PBM and Bloodless Medicine out of Inglewood, who brought so much insight to compassion and what it means for us. Ogago Udiru, who is a legal practitioner, and really thank you so much for the legal entity and aspects of all of this in medicine. Then we had Dr. Linda Shore-Lesserson also bringing us a keynote address, and she is a professor of anesthesiology with so much in-depth knowledge and experience. Also, we had Kelly Johnson Arbor, medical director out of Georgetown University Hospital in Washington, D.C., and Christopher Simutuo. Of course, we are so delighted to have you be our president-elect, and you will do a fine job, as we can already see. You bring so much to the table. Today, we want to thank Dr. Carolyn Burns once again for bringing and being and representing so much of what SABM has brought to BMSS and continues to bring, as well as Dr. Neil Bloomberg, wonderful lecture, by the way, and Dr. Erin Saddam. So, by the way, Dr. Saddam, your insight and input with massive hemorrhage is so well appreciated, because sometimes that is one that eludes all of us when someone is massively hemorrhaging. We want to stop the bleed, and the importance of stepping up quickly, even on a community level, is so important. And finally, Dr. Nadi Hakim, who shared with us his rich history of art and medicine, and really on a worldwide level scale. So those are the speakers. We have so many moderators that were included, and panelists that, maybe were behind the scenes more than seen. Due to time, I just want to thank you all, and we, on behalf of BMSS, want to thank everyone and show our appreciation for your input, your contribution, and your just support of being here. We had a volunteer I-team as well, and there was about 4 or 5 of them, Abel, Arjun, Roland, and Samuel, that were here and amongst us. Just wanted to say that Abel is an Osoro. And so we really appreciated getting to see Dr. Osoro's older brother, and there is that resemblance there. So that was truly a nice thing to see, as well as the secretariats, BMSS secretariats from Nigeria, Udiak Sunday and Blessing Ekpe, and finally all of our attendees. And really, we had a good outcome. Hopefully, every year we will see more support on an international level. I did want to, coming back to what Dr. Osoro said, want to relay the words that Dr. Jamila Sather had left, and she had sent an email. She could not be here today, and she was very sad that she couldn't. However, her cause is one that is equally as great, as she is now the president of My PBM Malaysia, and she just wanted to thank everyone, as she has gone at the she's actually attending the Thalassemia International Federation conference as we speak, and they are having their award ceremony today. So, but she wanted to thank everyone for the wonderful success and that everybody has brought to this webinar. So we do want to include her on that as well, even though she is not here, her presence is strong still. And again, everyone that had anything to do, I hope I did not miss anyone, but it has been a truly wonderful, insightful and rich conference once again, and moderators and also representatives or presenters, as we were able to have some of those brought to the table as well. And we really enjoyed the industry presentations as well. If I missed anybody, I apologize. Dr. Soro, is there anything else you would like me to conclude with? I'm sorry, you're muted, Dr. Soro.
Yes, I'm sorry. Sandy, I think you did a wonderful job of thanking everybody. The only thing I would like is for us to see the people who have been behind the scenes. So let me see. How do I, Roland, how do you get yourself here? Because I'm not, okay, I can do this, right? I think I can do that, right? So those are people who have been behind the scenes. This is one of them, Roland, operating out of UK from Scotland, helping us with the IT aspects of this conference, assisted. Oh, Arjun is, I don't know who is assisting who, they're assisting each other. Arjun is actually the chief host, doing all the streaming and all the stuff. He's also in Scotland. Is Roland here? I mean, Samuel. Samuel is not around.
No, I
So
think it's
two of them are
not
not.
here.
Okay, Samuel is not here, and my brother Abel is not here today, but I think he spoke yesterday. So I just thought we should see your faces and say thank you to you.
Okay, that's fine.
Thank you very much. So, yeah, that said, now let me find myself. Here I am. Okay, great. So, Sandy, our secretary, has done a wonderful job of thanking everyone. We cannot thank you enough. Speakers, panelists, attendees, moderators. We mustn't forget the moderators. Without them, the meeting would not have moved well at all. So we're very, very grateful to you for your moderation, and many others who did various things for the society. So we want to say thank you and goodbye until November 6 to 8, 2024, when we'll be talking about medical informatics. Thank you very much, everyone. And bye-bye. Let me remove my spotlight so others can speak and be seen.
Thank you very much. Thank you.
Thank you, Amit.
Sandy, you did it.
Everybody.
Good job.
Thank you again. And thank you, you all.
Congratulations, Christopher.
Thank you very much. Thank you.
Yeah, it will be seen again next year.
Yes, welcome aboard.
Yeah, we're going to Zambia after next year. We're going on a safari to Zambia.
Yeah, we are going to stop the live. Yeah.
Right.